All right, we are at 12:30 Eastern, so I'm going to go ahead and get started. Good afternoon or good morning to everyone joining us today, and welcome to the second annual ADCES State Policy Forum. My name is Hannah Martin, and I'll be your MC for the day. For those of you I haven't met, I'm the Director of Advocacy here at ADCES. I'm a registered dietitian by training, and I've been here coming up on 3 years. Really quickly, just want to go through some goals for today. First, we're going to talk about the importance of Medicaid advocacy. You're going to hear from 3 sets of speakers on key state policy and advocacy issue areas. You're going to have opportunity to connect with other advocates in your breakout room, and hopefully we inspire action for you to engage year-round after this event. So make sure that you have your microphone muted when we have our presenters talking. You're welcome to be video on or video off. During Q&A, you can put questions in the chat anytime the presenters are presenting or once we start Q&A. And you're welcome to also come on to camera and off mute during that as well. And we did have a number of meeting resources that will be dropped in the chat that is on our website. We will have a Q&A for every session, and go ahead and put those questions in as they come in. And with that, I'm going to turn it over to your 2025 ADCES President, Veronica Brady, and I will pull her slides up. Veronica, go ahead and say hi while I'm getting that up.
Well, hi, and hello, everyone, and welcome to the 2025 State Policy Forum. It is my pleasure to be here with you today, and I am excited to be with you for what is sure to be a dynamic and engaging foray into state policy. Next slide. So for those of you who don't know me, I am indeed your 2025 president for ADCES. And just to share a little bit about me, I am an assistant professor at the University of Texas Cizik School of Nursing. Say that 3 times fast. And there I work in the area of type 2 diabetes and comorbid diseases, primarily looking at type 2 diabetes and either HIV or type 2 diabetes and cancer. I also have a clinical practice at MD Anderson Cancer Center, and it's my absolute pleasure to be here with you today for this virtual forum. So just to give you a little bit of an oversight in regards to today's event, this is the second year in a row that we've had this event, and we have a strong attendance with over 250 of you registered for today's event, representing 46 states plus DC. And we also have members from the CDC grants. So for this advocacy forum, I've really come to understand the power of advocacy, ooh, my words, during this time of leadership in ADCES. And I applaud each of you for taking time out from your workday to learn more about these efforts and how you can get involved. I do want to share a special appreciation and welcome for the CDC grantees who are joining us today. So as you may know, in partnership with Emory University, ADCES has a 5-year cooperative agreement with the CDC to support 77 grantees from across the country as they implement evidence-based diabetes prevention management strategies that aim to reduce health disparities in diabetes. We are joined today by grantees from 26 states, and each of you will be interacting with ADCES leaders and members from your state during the breakout. And I hope this will be the first of many touch points for advocacy collaboration. Didn't know that word was going to give me so much trouble today. Today's events will focus heavily, although not exclusively, on Medicaid advocacy. You'll hear from experts today on how to advocate for your state's Medicaid program to have better coverage of diabetes prevention program and automated insulin delivery systems. Branching out from Medicaid, you'll also learn about the role of states in regulating pharmacy benefit managers to reduce the price of medications. I'm sure these issues come up regularly in your practice, and I hope you can use what you learned today to achieve in your state, to activate, to activate the things you learned today in your state to improve the diabetes prevention and treatment landscape. We are joined in our Zoom meeting today by many members of ADCES's Advocacy Committee. You'll hear from Janet on our panel later today, and you will see many others in your breakout groups if you're from the same state. In addition to helping to shape the state policy forum, members of the Advocacy Committee have been involved in planning and execution of the Public Policy Forum, a session at ADCES 2025, and presentations to state CB meeting attendees. As ADCES's 2025 president, I want to thank all of you for the work that you have done this year. I also want to thank this year's State Policy Forum sponsors. Our gratitude goes out to Dexcom, Insulet, Lilly, and Medtronic for their leadership in supporting this event in its second year. I also want to acknowledge their year-round partnership on state and federal advocacy issues and their participation in many of the advocacy coalitions that ADCES is involved in. By way of introduction of our speakers, we have a wonderful group of speakers for today's event. Following my comments, the ADCES Director of Advocacy, Hannah Martin, who is a one-woman show, will provide an introduction to Medicaid advocacy, and you'll hear from her throughout the day as she emcees this event. Then you'll hear from Jennifer Barnhart and Susan Buell, who serve as subject matter experts for our CDC grantees and have a long history of providing technical assistance to health departments, including several years of work to expand Medicaid coverage of the diabetes prevention program across states. Then you'll hear from two American Diabetes Association directors of state government affairs, Douglas Dunsavage and Christine Falavel, who will talk about ADA's new and growing work to expand Medicaid coverage to automated insulin delivery systems across states. The middle of our event is where we hope you will start to see your role in this work. First, we will hear from grassroots panelists who have directly advocated on issues being discussed today. Then we'll have breakout time for you to meet others from your state or region and begin to discuss areas of need and potential next steps to take after today. Moderated by ADCES Advocacy Committee Chair Janet Benefiel, the grassroots panel will feature ADCES board member Starlin Hayden Greeting, Cindy Lanfon from the Granite YMCA, and Jessica Von Golier, patient advocate from Massachusetts. After your state's breakouts, we'll come back to hear from our friends at the Diabetes Leadership Council and Diabetes Patient Advocacy Coalition about state PBM reform. That session will be presented by George Huntley, who serves on the ADCES Board of Directors, and the DLC DPAC COO, Aaron Callahan. For more detailed bios on each of today's speakers, please refer to the handouts that you received via email or those that are located on the ADCES website. And now for a shameless plug. Before we dive into the program, I want to encourage you to join me on December 12th and 13th in Chicago, Illinois, where I pray it won't be nearly as cold as it was last year, for the 5th annual ADCES Diabetes Technology Conference. Regardless of if you have ever worked with technology or if you've had years of experience in diabetes technology and you just want to dive a little deeper, this conference is for you. You'll get up to speed on all that's new and upcoming and understand how to maximize the value of technology for people with diabetes in your practice. We'll have a new activity called AID speed dating. And, dating, that's always good. And sessions on the growing use of technology by people with type 2 diabetes and gestational diabetes. And as a smaller meeting with fewer attendees, there will be lots of opportunities for you to engage and to network, as well as to have hands-on product demonstrations. It's a great conference, and I hope to see you in Chicago. And with that, I will turn things over to Hannah. Thank you.
Thank you so much, Veronica. And I am going to give just a brief primer on Medicaid advocacy for everyone, just to set the stage on what you're going to hear from many of our other speakers about later today. So before we dive in, let me just start with a short overview of our advocacy work as a whole, especially for our grantees who are on today who may not be members. Our department advocates to influence policy change through many different mechanisms. We do this working through direct action by staff and consultants, collaborating with other organizations, supporting our state coordinating bodies, and lifting up the voice of the DCES to advocate on behalf of our profession. And while most of our direct advocacy work is at the federal level and focused on Medicare as the largest single payer in the country, we also advocate on Medicaid at the federal level, and many of our state CBs are actively engaged to advocate for improvements in their state for coverage in Medicaid and other issues. By virtue of you registering and logging on today, you're probably already aware of the importance of advocacy, but I just wanted to remind you of some of the things that we have won through advocacy over the last 25 years, some of which were actually fairly new. We only have the DSMT and MNT benefits because of advocacy and RDNs as billable providers. Medicare copay caps and expanded coverage of CGMs are both fairly new policies, and we continually get wins on the regulatory side in DSMT, MNT, the Diabetes Prevention Program, and more. Just a quick civics lesson. In the US, we have federal and state governments with three branches, the legislative branch, executive, and judicial. And most of these, the legislature is a bicameral two-chamber body, and you have to pass bills through both of them to become law. You have your elected officials there. They are going to be re-elected every 2 to 6 years, just depending on your state. Then you have your executive branch of the state, which is going to be overseen by your governor and a series of appointed or elected secretaries that oversee the various agencies. And these are the folks that are going to make up the thousands of individuals and contractors and employees that carry out all of the activities that the state government conducts. And then lastly, you have your court systems that go by many different names across the state. And these are set up to have checks and balances over one another, writing laws, vetoing laws, interpreting laws, and then ruling if things are constitutional or not. We have a quick poll for you all today just to see where folks are on whether or not you know who your state legislators are. I don't know if we can launch that. There we go. Love it. Really high percent of folks that do know who your state legislators are. Impressive. All right. I'm going to keep us rolling on that. I think you can see the results there. Um, and for anyone who said anything except yes, definitely. Good news, we're not going to do this live today, but we do have a way on our website for you to look up who your state legislators are. You can click on this QR code. We will send the slides out afterwards, and you can find out who represents you. And then just a little more civics lesson talking about state and federal governments. Some things are going to be purely state, some things are going to be purely federal, but a lot of the programs that you're familiar with, including Medicaid, are going to be run jointly by both the state and federal government. In Medicaid specifically, they share who is paying for Medicaid. The states are paying between 20 and 50%. The federal government is picking up the rest. Federal government's going to set overarching guidelines on things that have to be included in Medicaid programs and populations that have to be or not allowed to be Medicaid beneficiaries. But then the administration and all of the details about exactly what services are covered and what people and how much they reimburse and all of that is going to be done by your state health department typically. And all of the work that we do here at ADCES is bolstered through collaborations with professional associations, other issue-based orgs. Our CBs have a lot of touch points with local collaborators, including employers, hospitals, health systems, et cetera, as well as our industry partners that Veronica mentioned earlier, who are part of many coalitions and day-to-day advocacy work that we participate in. And you're going to hear from some folks who are from these different organizations throughout the day today. But now I want to turn it over to Jen Barnhart and Susan Buell, who are two of our subject matter experts for the CDC match grants, and also true experts in the diabetes prevention program. They're going to provide us with our first deep dive of the day on Medicaid coverage of the DPP. And I will stop sharing and turn it over to Susan.
Excellent. Thanks so much, Hannah, for setting the stage on Medicaid advocacy and organizing today's event. And a very special welcome to Veronica and your leadership and highlighting the critical importance of Medicaid coverage and pharmacy benefit reform. Susan and I are so pleased to have the opportunity to share our insights on advancing Medicaid coverage of the National Diabetes Prevention Program, particularly through the lens of advocacy, strategy, and systems alignment. Today's discussion is going to focus on how states and partners can leverage policy, stakeholder engagement, and implementation strategies to expand equitable access to evidence-based diabetes prevention. We'll explore both the successes and ongoing challenges in achieving sustainable Medicaid coverage and implementation of the national DPP. And then on the next slide, just reintroduces ourselves. And a big thank you again to ADCES and be a part of today's community. A very big thank you to CDC and Match. Our colleagues at the Division of Diabetes Translation are very much in our hearts, as they have been and continue to be impacted by the government shutdowns, furloughs. I want to also thank the Emory Centers in partnership with ADCES for support through Match. And welcome also to our 2320 recipients joining us today. And we want to also thank the National Association of Chronic Disease Directors for their partnership in supporting the pre-existing and innovative body of work. So today, our session outline. Expanding Medicaid coverage of the national DPP isn't just about benefit design, it's about turning prevention into policy, very much what Hannah was talking about in the level setting up front, and ensuring that evidence-based care reaches the people and communities who need it most. As we'll discuss today, progress happens when advocacy and strategy really happen hand in hand and align partners across public health, Medicaid, CBOs to translate that coverage into access and ultimately into healthier lives. So we're really excited to share lessons from the field, emerging policy opportunities, and practical strategies to help you all sustain the critical work for the long term. We just want to note that we don't anticipate that you'll become experts at the end of today's session. And that's not the goal that Susan and I have for today. What matters most is your curiosity and commitment. We find that those attributes usually lead to the most positive outcomes in achieving coverage and implementation. And we're just so grateful to have such dedicated partners driving change in states and communities. And to Hannah's point up top, as you're listening, we invite you to reflect on where you see yourself advancing this effort, whether that's through policy, partnerships, implementation, or advocacy. So, to that end, please, throughout into Zoom chat, drop any questions, comments, and insights. We hope to have about 5 minutes at the end of this presentation for open Q&A. All right, so moving us to the next, would love to just briefly see a hands up. This is an orientation of our Zoom screen. Would just love to see a scan of our participants. So can you please put your hands up if you're a registered dietitian or diabetes educator? A lot of hands up. Excellent, excellent. That's the bulk of our audience today. And then moving into sort of a similar level set Zoom poll. So building on the awareness of who's in our room, we're going to go ahead and release a poll that is, what is your level of knowledge about Medicaid coverage mechanisms of the national DPP? And high, moderate, low, or none. And let's give it a little time here. Okay. I think we can go ahead and share the results.
Yeah, that'll be next month. Yeah. So we'll
Oh, can someone please put themselves on mute? I'm sorry. So the knowledge base of the audience looks mostly kind of hovering around moderate to low. Great. That's very much what this presentation was tailored for. All right, so let's set the stage for advocacy on the next slide. So when setting the stage for advocacy, I always recommend to partners that they stick to facts and use plain language when communicating to partners and stakeholders, and stay away from the politics of it. Stay away from the operational intricacies. And I would say, to that end, this slide represents the facts and really speaks for itself. The overall economic burden of diagnosed diabetes in the US is astonishing to me. The American Diabetes Association estimates in 2022, where the latest data was available, diagnosed diabetes cost to the US is $413 billion a year. And that's broken down across to clinical costs, which hover around 300 billion, and then about 100 billion for indirect costs related to comorbidities or productivity losses. Taken together, diabetes accounts for 1 in 4 of every US healthcare dollar. That figure also is overwhelmingly attributed to type 2 diabetes, which, as we all know, is preventable. So on the next slide, this sets us up really for a call to action. These figures create a substantial call to action for expanding Medicaid coverage of the national DPP, as grant funding is not sustainable. Moreover, peer-reviewed evidence has found that the national DPP delivers a strong return on investment, and it's generally inexpensive, with reimbursement rates averaging about $750, not as close as it costs to deliver it, and we'll talk a little bit more about that later on, but relatively inexpensive. And today, an estimated 12% of the US adult population has type 2 diabetes, and 1 in 3 adults residing in the US are estimated to have prediabetes. And so these percentages are higher even amongst the Medicaid population, which we'll be talking about today. And also, projections suggest that without prevention, the percent living with type 2 diabetes will sharply rise. People are living longer. Obesity is increasing. Prediabetes is not being treated. So without intervention, the national DPP, the economic, clinical, behavioral, and social burden of diabetes will expect it to sharply rise over time. So moving to the next page, for myself and other Medicaid policy experts like Susan, we're really closely tracking the signals of the impact of HR 1. A common talking point that I use when advocating for Medicaid coverage is that almost half of Americans actually receive their health insurance through public funding, Medicaid, Medicare, and military service related coverage. Of that, about 20% of Americans have their health insurance through Medicaid. So while Medicaid funding cuts are, well, they're currently being challenged through the government shutdown, assuming these cuts proceed as projected, there'll be a large cost shift to states to continue to fund Medicaid programs. So this will disproportionately impact state budgets through a reduction in how much the federal government gives to states in a federal matching manner. The impact of the Medicaid cuts through the proposed H.R. 1 includes changes to the Social Security Act, again, shifting a greater burden of Medicaid funding to states. But what does that mean for the national DPP? So in my mind, where this comes back to the national DPP is that CMS sets a standard for required benefits that state Medicaid agencies need to provide. And diabetes prevention and management are optional benefits. They're not required. So as states really scrutinize what their Medicaid budget can be, and they have to offer those required benefits, these optional benefits, like national DPP, may be lost as a cost-saving strategy. These benefits might be cut. So moving on to our next slide, public healthcare financing for the national DPP. In the next slide, I'm going to talk a little bit about Medicaid coverage mechanisms. So you can see we've got a lot on this slide here. There's a lot of different ways and pathways to enable Medicaid beneficiaries access to the national DPP through Medicaid coverage. The most permanent mechanism of coverage is through agreements that each state has with the Centers for Medicare and Medicaid Services. This is called the state plan agreement. And it can also be amended to add additional services, such as a state plan amendment. Another example of a type of agreement between the state and CMS is called an 1115 waiver. So the 1115 waiver is think of it almost like a pilot or a test, where whether a benefit, like for example, the national DPP, will be examined. Does it have an ROI? Is this something we should consider putting in through a state plan amendment so that there'll be more permanent coverage? I wanted to point out that, Susan, I, and many other Medicaid policy experts are really looking for different signals around whether 1115 waivers will continue. There's been clarity that CMS will likely not consider new 1115 waivers. And right now, we're tracking closely on whether existing 1115s will be renewed. So these have some vulnerabilities, the 1115 waivers, and state mandated coverage and state funded pilots are also vulnerable given the uncertain funding landscape for Medicaid. So this is where it brings us to the voluntary MCO offering, really pointing us to the importance of Medicaid managed care organizations. So Medicaid managed care organizations, or commonly referred to as MCOs, as you know them, are health plans. They can be national health plans, Blue Cross Blue Shield, United, Aetna, which some of you may have insurance through these companies. But they also offer a line of business that's for Medicaid beneficiaries. And across the nation, about 85% of Medicaid beneficiaries have an associated Medicaid managed care organization health plan. And the idea is that they do a better job in managing the members' care. So I would say too, I've circled this piece because Medicaid managed care organizations can offer the benefit voluntarily to their members. It doesn't need to be covered by your state Medicaid agency. And, many MCOs are increasingly seeing the value of offering this. And one thing that always sticks in my mind is I recall a chief medical officer at a very large MCO saying, diabetes management and treatment is one of the largest costs to their companies, insulin amputations, comorbidities. So why would we not invest in an inexpensive intervention that makes our members satisfied and saves our business substantially more money? And I just thought it really cut to the chase and has always resonated with me. And it's amazing to see an MCO champion the national DPP. On the next slide is really the map is largely a function of all the hard work that state health departments and delivery organizations have done to advocate for coverage. There are 31 states that have achieved Medicaid coverage for the national DPP, and on the right-hand side, you can see a key of all the different types of coverage mechanisms. The most common mechanism in the past, in the near term, has really been MCO-based coverage. And I also want to note that this map is maintained through the NACDD's National DPP Coverage Toolkit. On the next slide, we wanted to make a finer point about connecting up the National Diabetes Prevention Program with the Diabetes Self-Management Program. And just making a point that covering both DSMES and national DPP is an important strategy in a state because there is coverage across the diabetes continuum when there's coverage for prevention and also treatment. Many delivery organizations to that end offer both interventions because of that care continuity perspective. And in fact, 28 states have both coverage. So taken together, this really helps reduce progression and further complications. So reimbursement for the national DPP, just like other rates, are typically benchmarked against what Medicare pays for the program. So you can see here in 2025, our current calendar year, the physician fee schedule has the rate at $755 is what Medicare pays. And while this is a benchmark, states can exceed the rate. Some states also pay for year two of the program. And others have been able to establish MCO arrangements whereby they're getting reimbursement of $1,000. And Susan's going to talk about this a little bit more. I think that this is so critical for advocacy because reimbursement should ideally reflect the cost to deliver the program. And the cost to deliver the program can range anywhere from about $1,000 to $1,500, depending on the level of sophistication of the delivery organization and how long they've been delivering the program. So all payer approaches. Wanted to also just kind of put a pin around the importance of coverage from multiple payers. And so I just want to go ahead and offer some insights around other payers for the national DPP. And all payer approaches really align incentives, stabilize provider participation, and make Medicaid benefits themselves more sustainable and equitable. And they also really ensure that they're not done in a separate, underfunded system, but part of this overall driven healthcare ecosystem. I feel like a really good example of this, and I'll move into the Medicare DPP here in just a moment. A really good example of the importance of an all-payer approach is I go to my primary care physician. She recommends that I be referred into the National Diabetes Prevention Program, but she doesn't have any awareness of the plan, my health insurance. And so if my plan doesn't cover the National Diabetes Prevention Program, that referral pretty much is moot. And the cycle for a consumer can sometimes get caught up in not receiving services. As you can see here on the Medicare DPP, MDPP, as many of you know it as, the Medicare Diabetes Prevention Program, the benefit was launched by the Innovation Center at CMS in 2019. It's being delivered across 1,370 sites in the community. And CMS and CDC very intentionally continue to partner around how to increase uptake. Both in terms of enrollment of providers, but also of enrollment of Medicare beneficiaries, because it has been relatively low for the MDPP. As you can see, there's been about 9,000 beneficiaries who participated since inception. And on the next slide, finally, commercial and employer coverage. So most Americans get their coverage through commercial or employer coverage. Similar to MCOs, employers can adapt to deliver the program to employees because they see this enormous value by providing this benefit to their employees as it relates to productivity and retention. Commercial plans also have that same ability to do so and we've been noticing they're making substantial gains. And the commercial health insurance businesses, it helps them meet a number of set requirements that are put in place from a regulatory standpoint. In the current landscape, I'll just note consumer choice is really paramount, particularly as it aligns to driving business decisions. And that kind of comes back to our commercial insurance value proposition. So with that, it is a privilege to turn it over to my dear colleague, Susan Buell.
Thank you so much, Jen. I really appreciate the way that you laid out the national landscape, the indicators, that all-payer approach to ensure patient uptake and engagement of the National Diabetes Prevention Lifestyle Change Program. So I get to transition us to some tactical and key components as you're thinking about yourselves in that seat of, well, if I'm an advocate and I'm talking to any one of the organizations that are involved in Medicaid coverage, what do I need to know? How would I get to know that? What do I need to understand? So what I have the privilege to review with you is some competency building potentially for you, as the majority of you are yourselves practitioners and clinicians. Sometimes thinking about advocacy in the policy lane is maybe it's new or novel. So I'm going to talk with you about understanding where Jen shared about different resources to know what coverage does exist in my state. So spending a little bit of time looking at key performance measures that your Medicaid payers in your state might be striving to achieve. Also looking at learning more about how other states have set up their Medicaid, payer contracts for the National DPP Lifestyle Change Program. And thinking about how to articulate that potential payment model for Medicaid coverage. Building payer confidence through engaging individuals and beneficiaries in the program helps with contracting and contracting support. And we'll also look at some of those facilitators for engaging beneficiaries as part of your potential advocacy strategy. So there are lots of places where you can lean in potentially, and I'm going to share with you some of the resources to understand. So first, in the lane of understanding the folks who are providing Medicaid beneficiaries access, it's important to understand what their challenges are and how to speak to how offering the National Diabetes Prevention Program to their beneficiaries through a covered mechanism could support their uptake. And as Jen enumerated, this could be at the state level, it could be at an MCO level, it could also be at the payer level for states that aren't expansion states. There are case examples where an individual payer has taken those necessary steps for them as a sole business to contract to give their beneficiaries access. So thinking about some of the administrative burdens, whoops, I hit the wrong thing too quickly. Working with CBOs and what contracting can look like with suppliers. They're struggling to accomplish what outcome metrics are they struggling to accomplish? What are, as Jen noted, it's expensive to treat diabetes. What is the cost offset for treating those who have presented with risk of diabetes in advance of a diagnosis? And then looking at beneficiary engagement and retention. The National Diabetes Prevention Program can often be a great program for one more time, getting somebody into a clinic to get their A1C read and checked so that they know whether they qualify for the program. And those organizations that are delivering the National DPP are often community-based organizations that may be in a place to address those beneficiary or patients' upstream drivers of health in helping them get connected to the necessary resources that they need to accomplish their health outcomes and goals. So as Jen noted, on the NECDD coverage toolkit, and we will drop some links in the chat as we move through this resource-rich series of slides, there's a policy to payment page. And on this page, there are different stops at each step along the way as you're considering your advocacy role. So as you click, if you're on the page, there are actually little plus signs on the top right. And as you click on those, you'll be taken to places and spaces where you have access to deeper dive and tools. So One thing we wanted to highlight here is that on your first stop on the map, there is a resource that you can access, that can support how to articulate the cost and value of providing coverage for the National DPP Lifestyle Change Program, because there are a lot of variables involved in thinking through what is the benefit, other than we all know that prevention is a good idea, but there's some actual data and numbers there for you to access to think about how you might want to have those conversations with a policymaker or a payer or both. And then I'm going to move back to the same graphic, but with a different use case, and thinking about how to speak to your payer's needs, if that's the organization that you're engaging with, someone maybe who works in your state Medicaid agency, or if you're in a state that has an MCO, how to talk to an MCO, thinking about how to articulate that ROI and value on investment case to these different organizations. And then coming to the next stop on the policy to payment roadmap, it's important for you as advocates to consider what are the contracting nuances in your state for engaging Medicaid beneficiary coverage for the National Diabetes Prevention Program. You may have that state level reach and contracting, in which case, are there, what are the considerations related to credentialing that a payer might want to understand in the development of the contract, or those kinds of nuances related to how to attain appropriate reimbursement rates for the cost of delivering the program in your state. Many, many resources on this page, and the coverage toolkit can take you through those use case studies and give you examples of how other states have approached this work. So please know that you're not alone in this. We have a deep bench of resources available to you that we'll share through these links in the chat. And again, if you have questions along the way, we're here to work to address those. So to give you an example, I'm going to move you forward through, as you saw on the coverage map that Jen shared with you about different states and how they've accomplished Medicaid coverage for the National Diabetes Prevention Program. We're going to show you a little bit about a very thoughtful approach that Illinois engaged in to accomplish their benefit. So the Illinois Public Health Institute, IPHI, is the organization that was the neutral organization. So they didn't work for a state Department of Health. They are allowed to do advocacy work where some of our partners are more bounded by rules and constraints. Coming up with that neutral convener can be very helpful in initiating how they went about getting coverage. My click trigger finger is too ready this morning. Sorry about that. I'm on the West Coast, still morning where I am. So they focused launching this advocacy campaign as part of their Illinois Alliance to Prevent Obesity, and grew from there. And I'm going to walk you through the steps very briefly, just so that you can see this takes time, right? It may not take as much time as Illinois invested, but it does take time. So they started this initiative back in April of 2016, and I have two screens. So if I'm looking at this, I'm not looking at you. I just want you to know. They pulled all those stakeholders around a table and began to have a conversation. You know, we're seeing an increase in the obesity rates in our state and the comorbidities associated with those rates. What can we do? So they developed and released a bridging preventative care roadmap to Medicaid coverage of community-based chronic disease prevention and management programs, which is available through the link for the state story on the NACDD coverage toolkit. Then they engage those who'd be delivering the program. What would they need? How does it work? Let's start a pilot. And then they reconvene stakeholders in 2019 to see how things are going. Sometimes people assume, oh, we checked that box, but rigor and diligence in continuing to move the initiative forward is often required. You can see in 2020, they were able to accomplish a mock claims pilot to test what does it look like to bill for a new benefit, particularly one that isn't a required benefit under Medicaid. And then in 2021, their benefit went into effect. And in 2022, they implemented a state plan amendment, which was approved by CMS. So a multiple step, multifactorial approach. And again, I want you to note that not every state approach is going to look like this. Typically, convening stakeholders is a recommended and best practice. And Jen noted an example. She's actually talking about Wisconsin earlier, which is not a Medicaid expansion state, but the Wisconsin Department of Health worked to pull together all their payer partners under a state benefit plan network to work as a collective to decide together what do they want to address for the citizens or beneficiaries in Wisconsin. And they were able to establish with one of their payers $1,000 per participant for the National Diabetes Prevention Program at the beneficiary level for sustainability. So there are lots of ways to approach this advocacy and policy initiation beast that we wanted to share with you, that on the National Association of Chronic Disease Directors Coverage Toolkit page, there are multiple state stories of how they accomplished their benefit with Medicaid for the National Diabetes Prevention Program. And then just to note, because a benefit is in place doesn't mean that there's going to be uptake. So there needs to be a little bit of rigor as you're working with partners across your state or in your service area to ensure that the rollout and uptake of the benefit continues to happen, to identify where the sticky points might be in that, and keep things moving. So the beneficiaries ultimately are those that can get the good stuff out of participating in the National Diabetes Prevention Program. So I'm going to quickly walk through what I noted earlier, which is payers often feel more confident in saying, yes, we'd like to cover this if they can see volume and results. So in your seats as clinicians and practitioners, your ability to help move people into the program and work with your organizations that are delivering the National Diabetes Prevention Program to articulate outcomes that they are experiencing with their participants can go a long way toward helping payer confidence in engaging in covering the benefit. And again, as I noted, the upstream and related health-related social needs, that was redundant, the health-related social needs that a Medicaid beneficiary may be living with can often be addressed by community-based organizations that are working to engage folks in the National Diabetes Prevention Program. So we're seeing an emerging best practice come in the form of these centralized hub models that are addressing the pain points of those organizations that are delivering the National Diabetes Prevention Program may not be well versed in claims cycle management or contracting or some of the nuances involved in Medicaid coverage for the National Diabetes Prevention Program. So we wanted to share with you quickly that there are two emerging models, the Community Care Hub model and the Umbrella Hub model. Umbrella Hub model was originally developed specifically for the Diabetes Prevention Program. We are seeing advancement of those models into greater spaces for evidence-based program service delivery, including some of those social drivers of health, transportation, nutrition, childcare supports to help beneficiaries who are engaged in the program be more successful. So in the slides that and resources that Hannah will share with those who are attending today, we do have some follow-up resources here for you about where these hub organizations are. So again, you're not alone. You could reach out to one of these organizations to consider learning from and with them about advocacy for helping engage and advance beneficiaries in the National Diabetes Prevention Program. So some quick high points about advocacy actions that move the needle. We did talk about knowing the Medicaid coverage status of your national DPP in your state, thinking about what the payers are struggling with and trying to accomplish, thinking about looking at their publicly available HEDIS measure and other performance outcomes to see what it is that they're struggling with to help articulate your advocacy case, understanding certainly your Medicaid beneficiary needs that you're working and serving with, and then learning more about the hubs in your service area. Many of those hubs on the maps that I quickly shared on the screen, many of them have a multi-state reach. So it may not be, if you don't have one in your state, it doesn't mean that you don't have access to those services. Again, this is our NACDD National Coverage Toolkit, our coverage toolkit with lots of information that could support you in your advocacy efforts. And then I just wanted to pause. I know we're almost at time, Hannah, to see if, Jenna, there are any questions in the chat that we would like to grab.
I don't see any yet. So if anyone has any questions, please put them in the chat. And thank you, Jen. Wanted to make sure everyone saw all of the links to resources that Jen has been putting in the chat while Susan was talking. Many of those resources that were referenced are already in the chat for you.
Wonderful. Well, we thank you so much for the invitation to be with you today. We recognize that this is the headwinds that we're facing as a nation cause us to be in different seats and think through creative strategies to make sure that our patients and clients are being served to the maximum capacity. So we appreciate your courage in stepping in the advocacy consideration and lane. And please know that we're here to support you along the journey.
And
Thank
we
you so
did
much.
just get a question.
Oh, great.
We have a participant asking if there are any validated outcome measures that would be most useful to track in pilots.
Yeah,
Jen,
I can start. Yeah, and Susan, please add in. So I would say that one of the most important things for starting pilots, and Jessica, thank you so much. It's a great question. Is yes, beginning with like the end in mind for sure. What are some of those outcomes being tracked up front? I think what's really important as benefits go live is to think about some of those qualitative measures. And they can be enrollment of providers. They can be national DPP provider enrollment into Medicaid. They could be Medicaid managed care organization contracts with those providers. Certainly, enrollment of Medicaid beneficiaries is another goal. I'll say Susan and I, we in earlier this year, we were having a lot of discussions with CDC about how to potentially leverage the DPRP data for some of the work that's ongoing and sort of matching that from a longitudinal perspective. There are no specific validated measures, though, I should add, for diabetes. And this is something that CMS Medicaid has been working on in addition with the American Medical Association for state Medicaid agencies to adopt a core measure that they could then hold their plans accountable for. Susan, thank you for putting a finer point on DPRP, the Diabetes Prevention Recognition Program that recognizes the delivery organizations.
I would also add the other just baseline validated measures of the program itself in terms of what's tracked, physical activity minutes, weight loss, participation. Those benchmarks that trigger payments are also performance measures in terms of folks' ability to accomplish the evidence-based outcome that was established with the research around the National Diabetes Prevention Program.
We have one more question that's come in. Someone noting that a lot of their participants don't know what type of coverage they have, or they may have multiple insurers. Do you have any suggestions for strategies for educating the public about what their benefits might be and what's available to them?
Yeah, it's another great question. Thank you, Timothy. One thing that lifestyle coaches are the trained providers that deliver the national DPP. And one of the strategies that many of them will use will be do you have a health insurance card in your wallet? If you're Medicare, is it the red, white, and blue card, Medicare fee for service, or does it have a plan's name on it, like a Medicare Advantage plan? So not so much sort of broader, but just more in practice at some of those initial sessions, discovery sessions with potential participants.
I would also note that your hub partners in your state or region have standard operating procedures and practices related to beneficiary education. We have worked with some plans that do that very actively. We've worked with some plans that don't. So I think your question is spot on in terms of gaps and ways that we could continue to improve to wrap around understanding for beneficiaries. Thank you.
I'm not seeing any more questions in the chat. And I know our friends from the ADA who are up next are on. So Just wanted to give you a really big thanks, Susan and Jen, for being here. We really appreciate your expertise and bringing this lens of DPP advocacy to the folks here. I love to see all the hand claps on the screen. All right. Next up, we have Douglas Dunsavage and Christine Followbell, who are both State Directors of Government Affairs with the ADA. And they are here today to talk with you about improving Medicaid access to AID systems. I think you should both have the ability to share your screen. So whoever is running your slides can go ahead and pop them up. Welcome.
Doug, do you want to share your screen or would you like me to share mine?
Would you mind sharing yours?
Not at all. Okay, good morning, everyone. How's everyone doing? Pretty good? Okay, great. Great to see so many faces. Unfortunately, Hannah, it's not letting me share my screen.
My colleague behind the curtain is probably working on this. If not, I have a copy of your slides and I can share if needed.
Okay, I'll try one more thing.
Yeah, you should be able to. Do you have the share button on your screen? Is it an option?
I think we're in.
Yes.
All right. Well, good morning, everyone. Thank you so much for the opportunity to speak about improving access to AID systems. I think we'll just go like this. My name is Christine Falabelle. I'm a Director of State Government Affairs and Advocacy with the American Diabetes Association, and I cover the Southwest region of the United States. I'm based in Denver, Colorado, and I have my colleague Doug with me today, and we are co-presenting on improving access to automated insulin delivery systems in our Medicaid landscape across the United States. I myself have lived with type 1 diabetes for 25 years, and I personally use an AID system, otherwise known as a hybrid closed loop system. Artificial pancreas was a popular term maybe 5 or so years ago. And I'm sure you all know this, that these devices are truly life-changing, and we are trying to increase access as much as we can across the country. So I will kick it over to Doug, who will start our presentation. And let's go. And then ask any questions in chat as we are going through the presentation. And we have some time at the end as well for questions.
Thank you, Christine. So I'm Douglas Dunsavage. I am a colleague that works closely with Christine. I am the Government Relations Director for the Southeast and South Central region. And I've been with HA for about a year, but I have been in public policy and advocacy for the past 25 years, and very excited to share and be a part of this. Very honored to be here. So thank you. I want to just give a quick background. We just on the American Diabetes Association, we envision a life of free of diabetes and all its burdens. And ADA aims to prevent and cure diabetes and to improve the lives of all people affected by diabetes. And we achieve this through groundbreaking research, bold advocacy, trusted education, and meaningful connections. Next slide. So what does ADA advocacy do? Well, I think the first thing to sort of set forth is why advocacy? And that's the importance and urgency to address diabetes, both to prevent diabetes, but also to address diabetes as a disease in general. And diabetes is invisible. If we don't make our needs known, who will? And then just to give a quick sort of definition of advocacy, I look at it as sort of the strategic act of influencing decision makers to shape opinions, priorities, and actions around a specific cause or issue. And specifically, a process that aims to develop and pass formal public policy in our case to create lasting systematic impact. And formal public policy does that. The ADA team focuses advocacy on the federal level, the state level from a grassroots perspective, from a legal perspective, and from a policy perspective. And our policy areas, I call them buckets, include research. So really working on NIH funding, the prevention. We work a lot in terms of obesity treatments and diabetes prevention all across the country, across numerous issues. Healthcare access and healthcare in general, and then stopping discrimination in terms of people with diabetes in numerous settings. And some past wins examples include insulin affordability, access to CGMs, safe at school, and then improving Medicaid access to AID systems that Christine mentioned is an evolving issue and a new issue for us that we've just sort of taken on this year because we realize that a lot of the states aren't keeping up with the diabetes technology and a lot of the regulatory and legislative laws and regulations in states need to be updated to ensure that people have access to the most up-to-date technology and that people can have access to a lot better care. Next slide. So how do we do this? And I'm going to give a little bit of background just in general, knowing that this is a public policy forum. So in terms of moving public policy on the state level and even on the federal level, but specifically on the state level, because we're a nonprofit, we don't give money to political candidates. We use our brand. Most importantly, we use our volunteer base on the ground to tell the story. And I really appreciated the previous presenters in terms of sort of just the facts. And the thing that we also have going for us is science and the facts of what is actually happening as it relates to diabetes care across the country and the costs of that. And so we use a lot of our information as a tool of power in terms of influence. So I broke it up into 3 different areas that we really look at and the tactics and how we engage in our efforts. So from a legislative perspective, we do direct lobbying. So educate and influence lawmakers on diabetes policy priorities. And when I say legislative and regulatory, there's 2 different ways that you can influence public policy in states, and one is through the regulatory process and one is through the legislative process. The legislative process, you're actually going to decision makers, assessing who can make those decisions to move actual legislation. I'm just a bill, an ordinary bill on Capitol Hill, but it really is about moving legislation through the process in the traditional term. On the regulatory side, you directly lobby the administrative staff of agencies, who a lot of times have more power than the actual legislators as it relates to public policy and making decisions. A lot of times laws get passed and the agencies have more power in terms of actually implementing those laws on the regulatory side. And in terms of rulemaking authority, a lot of the agencies draft the actual language from the legislation and put it into their regulations on the state level. So a lot of power is held on the regulatory side, as much as if you just go to the legislature and get bills passed. So we educate and influence lawmakers on diabetes policy priorities. And I did want to mention, yes, so the grassroots mobilization. So we garner a lot of influence through our grassroots mobilization. And that means getting advocates to send emails, make calls, and meet with elected officials. And I would just say, in terms of meeting with elected officials, a lot of folks think this is sort of a pie in the sky when we bring volunteers to the Capitol. We really want them to understand that telling the story, telling your story, brings as much power in terms of what you're advocating for, then sometimes it's the most powerful thing, especially if you're a constituent. So I would really encourage everyone to know who your elected officials are. And as you're sort of developing advocacy plans, strategic plans, as you're moving to influence public policy, to make sure that these folks really want to hear from you, especially if you're a constituent. And so when you're going in and you're meeting with elected officials, it's very important to tell your story. So using personal stories can be incredibly impactful. And then media advocacy is another sort of tool in our toolbox. So publish letters to the editor and op-eds to shape public opinion, leverage interviews, press releases, and earned media to highlight policy priorities. And so those three areas we wanted to sort of pull out as we sort of talk about that as you all go into your breakout groups this afternoon, really thinking through and drilling down on maybe these three areas, because this is what we do in terms of the American Diabetes and are very successful at it. Next slide. I'm going to turn it over to Christine here in terms of the technical aspects of AID systems. And I will join you back in a couple of slides.
All right. Well, thanks so much, Doug. Really appreciate it. So as Doug mentioned, our priorities at the ADA include everything from improving access on health insurance to addressing affordability for insulin and other diabetes medications. We recently had a big win in California last week when Governor Newsom signed Senate Bill 40 and then announced the launch of CalRx's insulin glargine starting in January. So we engage a lot in that bucket, school and work discrimination issues. But now more than ever, we're diving deeper into the issues of technology. And so there's no going back. When I was diagnosed with diabetes 25 years ago, it was, take some Humulin R, test your blood sugar 10 times a day, and best of luck. Don't ask my parents how I survived college because I don't know. But we're not going back to those days where, technology is everywhere and we are utilizing it more than ever to improve health outcomes of people living with diabetes. And so we need to update, especially Medicaid, regulatory policy to match what is standards of care now. So part of that is increasing access to continuous glucose monitoring systems and improving access to AID systems or hybrid closed loop systems. So the benefits of an AID system, and I don't think I need to dive too deeply here. I think everyone is pretty familiar with them, but if you're not, historically, someone with diabetes would have an insulin pump, or you would do MDI, multiple daily injections, and then test your blood sugar. And having diabetes is kind of like driving with a blindfold on and someone telling you never go over 60 miles an hour. You didn't really know where you were. If you tested your blood sugar at one point in time and you were 80, you don't really know if you're 80 and headed straight up because you just ate a brownie, or if you're 80 and you're headed very quickly down. It didn't give you all that much information. And then based on that number, you would take insulin and kind of guess throughout the day. It got better with insulin pumps and CGMs. CGMs, of course, you could see a trend line of your blood sugar over the course of a day. And that was extremely helpful for kind of predicting where you were heading and where you've been, especially overnight. That was very helpful. But, I'm sure many of you can relate. Having an insulin pump and a CGM was great, but I would wake up in the morning and still see the dawn phenomenon. I'd wake up at 260 and I would just see the trend line, heading up every single morning starting at 1 a.m. And it's like, what can we do about this? And it seems like the easiest thing is have an insulin pump communicate with a CGM system, but it took a lot of technological progress to get there. And we finally are here. And there are several FDA approved AID systems on the market. And it's pretty much As I explained, an insulin pump responds to CGM readings and makes automatic insulin adjustments accordingly. So we call it a hybrid closed loop system or an AID system because it's not completely closed. What a completely closed system would do would be release glucagon if your blood sugar is too low. And we're not there quite yet, microdosing glucagon to help your blood sugar fall. But what we are at is an AID system will suspend insulin or decrease your insulin to help taper the low so you don't completely crash. And it's not like an AID system is perfect. It certainly isn't a cure, but it does decrease the incidence of highs and lows throughout the day. So it optimizes those glucose levels, and it lets you live your life. It adds a lot of freedom to exercise, to, eat more freely. A lot of people report, myself included, that you don't have to be as strict with carbohydrate counting. I come from the era when you had a kitchen scale and you were literally weighing your rice to get every gram of carb. And if you were 5 carbs off, your blood sugar would really drastically spike. But AID systems kind of smooth it all out because they can sense your blood sugar rising if you're under counting carbs and compensate for that. It helps reduce the risk of complications both in the short term and the long term. So short term, those acute highs and lows kind of calm down. And then because of, lowered A1C levels, it does decrease the risk of complications later on down the line. And as I mentioned before, it just lessens the burden of managing diabetes. We all know that diabetes is 24/7. You never get a break. But it is nice sometimes, myself included, to kind of forget that I have diabetes for even an hour or two and look at my CGM and say, wow, I'm 97 and I didn't even have to think about it. That is a nice change. So it is the standard of care. ADA's 2025 standards of care, we now recommend it as the preferred insulin delivery method for youth and adults with type 1 diabetes. Right off the bat, it's the best thing on the market for people living with type 1. And we also recommend AID systems be available for people with any kind of insulin-dependent diabetes. Even if you are just on long-acting glargine insulin, it can be very helpful to, increase and decrease your basal rate throughout the day. So the more we learn about these systems, the more we have found out that just taking, say, 20 or 30 units of Lantus at 10 p.m., it doesn't serve you because throughout different points in the day, you may need more or less insulin. And so these AID systems can really respond to an actual human living in the actual world instead of a patient just being very static in the clinic. And the ADA does believe that we should preserve choice in AID systems. People have different wants and needs. For me, I really love the tubeless insulin pump. I like being active. I don't like having my tubing caught on, a door handle or being ripped out. And so that works for me, but I know other people who maybe require more insulin in their pump and they don't like the tubeless system as much. So we do want to preserve choice, and we don't believe that every system is perfect for every single person. So what's the ADA doing to increase utilization of AID systems? And so our standards basically say we want to ensure people with insulin-dependent diabetes have access to these systems. It is the standard of care for people with insulin-dependent diabetes. And we want to make that access as easy and accessible as possible. So we want to get rid of burdensome prior authorization requirements, both for clinicians and patients. We've seen everything doing our scan of the country. We've seen A1C thresholds. We've seen C-peptide testing, multiple daily injection minimums. We've seen a lot of barriers, and we feel that they are unnecessary because this is the future and technology is only going to increase, and we don't want to leave anybody behind. We also believe in continuity of care, and that Medicare enrollees, when they hit 65 and they enter Medicare, should just have uninterrupted access to their AID systems if they were using them previously on private plans or in Medicaid. So we're working to address these burdensome requirements both on the clinician side, because we hear from clinicians that they're doing more paperwork for appeals and prior authorizations than actually caring for their patients. And every day, every month that patients aren't able to access these systems, their health is suffering, right? You can't put pause on your diabetes until your prior auth is approved. And so we want to make sure that patients feel healthy, they have access to, the tools and technologies they need to thrive with their diabetes. So unfortunately, Medicaid has a lot of unnecessary barriers. This is what we're finding in our research. Private health insurance plans are pretty good with their coverage of these AID systems. Of course, there are exceptions anywhere you look, but what we're seeing is Medicaid, their regs are outdated and they're not updating their coverage policies. And so, they have really burdensome criteria requirements for anything from insulin pumps, CGMs, and of course, AID systems. We've seen some Medicaid programs, they'll cover only one type of insulin pump and only one type of CGM, but they don't talk to each other, and so that's not helpful. Or they'll cover, say, a Medtronic, but they won't cover the Guardian CGM that goes along with it. And it's very frustrating. It's frustrating to see as a person living with type 1 diabetes. And I can't even imagine how frustrating it is for someone on a Medicaid program just trying to access this new technology and they're not able to get it. So the ADA is focusing on 2 state Medicaid plans currently based off of our research. And I'm throwing it back to Doug here in 1 second, and he'll talk about the 2 states that we're focused on right now. These are some of the requirements that we are asking Medicaid agencies to drop. And so one of them is the test for C-peptide, and that is basically a test to determine between type 1 and type 2 diabetes. Oftentimes, C-peptide testing is helpful in adults who are diagnosed with ultimately type 1. But if you present in the clinic with a blood sugar of 500 and you're, say, over 18 years old, a lot of people will just assume that you have type 2 diabetes. We've seen patients get a prescription for metformin, a glucometer, and they're shuffled out the door. And then 3 months later, they come back in, their A1C is a 14. And then finally, we get the C-peptide test, and it turns out that they actually have type 1 diabetes. And so, unfortunately, the C-peptide test, although very helpful to determine the type of diabetes, by the time you are getting an AID system or an insulin pump, it's pretty well established that you have insulin-dependent diabetes. And we don't believe the C-peptide test is crucial for getting an AID system per se. It is great and necessary to find out what type of diabetes you have, but once it's established that you need insulin, we feel it should not be a requirement to get an AID system. Other barriers that we are seeing is that someone to continue their coverage for the system be seen every 3 months. And if anybody here has tried to get in with their doctor, you probably know that that is very, very difficult, sometimes impossible. And so we are just asking that that be bumped up to every 6 months instead of every 3. If someone is not seen every 3 months, they could fall off their coverage and then it's not being reimbursed, and then their health suffers as a result. We've also seen many patients with a diagnosis of type 1 diabetes, and a Medicaid program will make them wait to access an AID system. They want to see someone counting carbs and taking injections for 6 months before they'll approve it, or up to a year before they'll approve it, which we don't feel is necessary. It's, kind of similar to you're making everyone do long division when a calculator is right in your pocket. Why go back? Why make people, suffer for up to a year before getting access to an AID system? While we do acknowledge the importance of knowing how to count carbohydrates, how to dose manually, how to test your blood sugar manually in case of a tech failure, which does happen, we don't think that someone with type 1 diabetes especially should wait so long to access an AID system. And we want to ensure access for people with type 2 diabetes who are on insulin, because they deserve access to this technology just as much as people with type 1 diabetes. And as I mentioned earlier, ensure patient and provider choice. We don't want to put anyone in a corner saying you can access an AID system, but only this one specific brand, especially if it doesn't work for their lifestyle, or their health goals, or their health history. What ends up happening is they won't adhere to the protocol, they won't like it, they won't want to do it, and then they'll be back to MDI and a glucometer. So we want to make sure that people can test out which technology works best for them and really enjoy it. Dare I say, enjoy their diabetes management. So this is what kind of we're working towards. All right, I'm going to throw it back over to Doug, and he's going to talk about Minnesota and Georgia.
I'm going to talk about both these slides, and then I'm going to sort of go into a little bit of detail in terms of the policy campaigns in both Minnesota and Georgia. I'm going to speak to Georgia more specifically, but so what we did was we did sort of a as we looked at this issue across the states. The majority of the states need to update their technology language within their regulatory language. And so we did a scan of all 50 states, and we, because it is a new issue, we sort of picked two states where we felt we could move the needle as we initiate these policy campaigns across the country. And it was Minnesota and Georgia that we've identified. And so we're advocating for changes to the insulin pump criteria in the Minnesota Healthcare Programs Provider Manual. And it's fairly simple as it relates. I know that the details in terms of this we can expound on, et cetera. But in terms of the actual policy change that we're asking for, we're actually going into the provider manual in these states and remove the requirement for C-peptides testing, as Christine sort of mentioned, change the insulin specification of 3 times a day to align with the CGM language. So we worked on expanding and getting Medicaid to pay for CGMs across the country, and we've reached an amazing point. I think we're up to Christine, I think it's 39 states or maybe a little bit more in terms of ensuring that CGMs, at least in some form or fashion, are being covered in states across the country. But we want to, as we've gotten this done, we need AID systems to align with that CGM language. And then in Minnesota, also remove self-testing requirement of 4 times a day. That's very burdensome in terms of the patients. And so those are the 3 areas that we're really sort of updating in Minnesota. Next slide, Christine.
And I will mention one thing about the testing 4 times per day. What we have
Yeah.
seen is that sometimes Medicaid won't even cover 4 test strips per day, but their requirements to get an AID system will require 4 tests per day. And so it is actually impossible sometimes for someone to meet the requirements to get an AID system, which is just completely unfair. But okay, Georgia.
And as we pass these policies, there sometimes can be unintended consequences as it relates. And so as we've done this scan, we want to go back and sort of close, forgive the pun, close the loop as it relates. And in Georgia, we are advocating for updates to the Georgia Medicaid coverage manual as well, and restricting to type 1 diabetes diagnosed before age of 30. We want to take that out, requiring specific elevated A1C thresholds, documenting multiple daily injections and numerous dosage adjustments, mandating frequency of glucose testing or C-peptide thresholds, and requiring extensive hypoglycemia or dawn phenomena documentation. So in Georgia, there's a little bit more that needs to be updated. And we work with our internal policy folks to sort of identify exactly how we're going in and what we want to get changed so that we can mitigate those unintended consequences as we move these policies forward. It's harder to go back than it is to try and get as much as you can changed in process. And so what I'll do is expand a little bit on how we're going about these policy campaigns. So right now, because just the manuals need to be changed in Georgia and Minnesota, ideally we would like to work the regulatory process and change these manuals. Uh, and we're working with the agencies, the Department of Health. They're called different things in different states, but the Department of Public Health and the Department of Community Health in Georgia specifically. But what we're doing as a tactic is we're putting together a roundtable. So we're identifying the decision makers from the legislature around this, and then we're bringing Medicaid, the agency folks, to the table, and we're doing roundtables in both Georgia um, and Minnesota to sort of get the discussion going around why this is so important, and to look at cost. Obviously, in a lot of the issues that we work on, not just AIDs, but in a lot of our areas in terms of uh, ensuring that Medicaid has these coverages in obesity treatment, in CGMs, in insulin copay, all of it a lot of times comes down to cost. And so we want to make sure that there's open lines of communication between the legislators who are making the decisions on the appropriations for these budgets, and then also the agency folks so that they can get an understanding of sort of what needs to be done, and also getting a sort of a vision of what that looks like. And so these roundtables are incredibly helpful, and they're going to be next month in both of these states. And we're also bringing clinicians in to sort of talk to the technical aspects of why changing these. And Christine does a beautiful job of sort of highlighting that, but a lot of times legislators and even agency folks really need that in the weeds information so that they can get a clear picture of what these changes need to look like. So all that to say, that's one of the tactics that we're using, is coming up with roundtables in these states. And then if ideally, as I alluded to earlier, we would like to get this changed just in the manuals. And you need to make sure that when you're changing manuals in language, that the agency has the rulemaking authority to do this. In both Georgia and Minnesota, they do have the ability to change these manuals. Sometimes there's a barrier that they don't have that rulemaking authority. We've assessed that. So we're really focused on getting this done on the regulatory side. If that doesn't happen, and we see that this isn't going to move, or it's going to be a couple of years before it moves, then we will pivot and make the decision to run legislation, which has its own obstacles, has its own barriers as it relates to getting bills passed. But we're looking at both, so we thought that this would be a very good example of a policy campaign where both regulatory and the legislative processes could come into play. And if you are going the legislative route, I think in the previous presentation, coalitions were mentioned for these types of efforts. And because we are nonprofits for the most part, coalitions can be a huge bonus as it relates to having different associations and organizations and groups coming together to initiate these changes from a legislative perspective. And I think that is what I was going to talk about. And so I'm going to kick it back to Christine now to tell you all how you can engage with our association. And I hope this has been helpful, and have a great rest of your day.
Thanks so much, Doug. Now we will zoom out from the weeds a little bit although I know how much we love it. We want to partner with you, and so that's where you guys come in. So our advocacy work is dependent on other people. As Doug mentioned, coalitions with patients, providers, advocates, volunteers, other nonprofit organizations. As advocacy leaders in this space, we want to work with you to achieve our goals. And I think that we all have very similar goals, and that's improving the lives of people living with diabetes and type 1, type 2, pre-diabetes, preventing diabetes. And this AID project is a big one for us, and we're very excited for it. So we'd love if you send me a note. I can put my email in the chat if you want to get involved. If you're in Georgia or Minnesota especially, that would be fantastic. You can also sign up to be an advocate and receive our quarterly advocacy newsletter, which is brand new this year. So that's very exciting. And also, if you sign up, we will not bombard you with emails, but you will be alerted when there's an action to take in your state, and via an action alert to reach out to your elected officials, contact the governor on a bill that's pending, and get involved that way. And so we would love to work with you.
And I
And
would
if you
just
want,
add to
yeah.
that, Christine, that our when you do sign up, our platform specifically targets your legislators. So
Mhm.
if we're not targeting your legislator, a lot of times you won't get that email. But so it is important to put the address where you vote, because that gives our system the ability to target specific legislators, um, all the way down to the city council level, um, to get the messages out and to ensure that you're engaging proactively and effectively.
Yeah, it is funny. Sometimes we have advocates sign up and they're like, I don't get action alerts. What's going on? And I'm like, well, you must live in a really great state where not much has to be done right now. So if you don't hear from us, sometimes that's a good thing. Um, and if you are tech savvy, which since this was a tech related talk, you can scan the QR code and it will take you right to our website to sign up to be an advocate. So I'll leave that one up for a couple of seconds. And I think that is the end of our talk. If you have any questions, you can raise your hand in the chat, and
Yeah,
we'd be
we have a
happy to answer
couple in the
them.
chat already.
Okay.
Um, First, very basic question that everyone will need to know the answer to work on this. How can you check to see if your state Medicaid covers AID?
You could
Is
reach
there a
out to
map or
us.
is this is this a wild goose chase or what?
Well, we did a 50-state scan of all the language, both on the legislative and regulatory side. So we have that internally. We haven't put together collaterals for that, I don't think yet. So the best way to find out sort of what that looks like would be to reach out to Christine or myself, and we can figure out sort of exactly what it looks like in your state. Is that the best way to do it, Christine? I think that's
I think that
probably
would be the best way. Yeah, I'll put my email in the chat, and if you have if you have a question about your state, we can easily find out for you.
absolutely, and I'll do mine as well.
Great, thank you. We had an earlier question when Douglas, you were talking about updating the manuals in those two states. How often are states required to update their policies and or guidelines, and what prompts these updates typically?
That's a great question. And if you've seen one state's manual, because every state, even in like, if you looked at the bullets, and I think they're going to provide the presentations to you all afterwards. But even in like Minnesota, there's only three things that need to be changed, and in Georgia, there's six. Um, and so, or in terms of updating, so it just depends on the state, and where it's placed in the state. A lot of times, so the manuals that we're updating in these two states, um, are unique because they have an umbrella, coverage that gives rulemaking authority to the departments to update their manual, and that becomes formal policy. But in Georgia, it's every year they look at this. In other states, they can open it up anytime. And then in some states, you have to get the actual regulations changed. So the manual is an administrative sort of change, whereas, and there is a difference between administrative change and regulatory change. The rules are defined by legislation and then are written by the agencies. In this case, they allow for the Medicaid departments to update their coverage manual, and that becomes the formal public policy. But a lot of times you actually have to go in and change the regulations themselves. And so, but it really depends on the state in which you're working. So if you've seen one state Medicaid rules, you've seen one state. So, and that's kind of the challenge. A lot of this is sort of looking at and making sure that you're doing your diligence to understand what this language looks like before you sort of undertake the policy, because you can be spinning your wheels if you don't know who the decision makers are that you're targeting.
We have a question specifically on Georgia, and you may be a little early in your efforts to answer this, but are you getting any pushback or resistance thus far on this change in
I'm really
Georgia?
glad that question was asked because I forgot to mention this in the spotlight. But the AID updates, we aren't anticipating a ton of burdensome cost. This is really sort of bringing folks up to speed. It isn't like working on obesity treatments for pre-diabetics in terms of obesity medications or bariatric surgeries or intensive behavioral therapy even. The cost, we're hopeful, but because this is so new, we are monitoring what it's going to cost. So, but it's not like some of our other issues that cost upwards of $100 million, $200 million a year. And so the pushback, we understand that cost is the major pushback on all these issues when you're asking, especially in this climate, going into the headwinds, as our previous presenters said, with everything that's happening on the federal level, and a lot of stuff's unknown. So it's the Medicaid programs are very hesitant. It's not that they don't think that these things are good ideas a lot of times, and we're seeing this in the States, but that they are hesitant to do anything until we get more specifics. Yeah, we see the 900, the 900 number that's going to be over 10 years. But what does that mean for those specific states? And so there's a lot of ambiguity still out there. And so it's not so much that we're getting pushback on whether or not this should be funded. It's just they're very hesitant to commit funds as it relates. So I think the biggest obstacle is being proactive, especially in this case in terms of the AIDs, to understand more of what it really is going to cost. And so we're very much monitoring the response that we get back from these roundtables, from the agency folks that are that will eventually come up with the fiscal impact when they request this in their budgets coming up in most of the legislative sessions in the spring.
I will say also some of the pushback that we've seen is just around stigma. And so that's really on all of us to
Great point.
educate and increase awareness. I can't tell you how many Medicaid directors I've worked with that think people with type 2 diabetes don't need insulin. Right? I mean, that's just what people think. And now with GLP-1s out there and metformin is so common, you say type 2 diabetes and they say they're not on insulin. And so I think these roundtables will also increase awareness. It's interesting because in our little diabetes bubble, and especially living with diabetes, and I'm sure there's a lot of CDEs on the line, it's our every single day. And so we're like, of course, you know what an AID system means, but I mean, I have worked with a Medicaid director who did not want to offer CGM coverage. This was a few years ago, because they thought that kids could reverse their type 1 diabetes. That was their recommendation. And so there's so much misinformation out there that I think it takes all of us to just increase awareness and really educate on the technology, the tools, the terms, and the stigmas that exist.
I want to thank you both so much for being with us today. Really appreciate your insights and your examples that you gave on those two specific states. They did both put their email in the chat, so especially if you live in one of the two states they talked about today or live in one of the many states that the two of them collectively cover, do be in touch. And then same in the other direction, we often get outreach from ADA that I've put a number of you are state leaders in contact with various state directors there. So it's a really great partnership. Super pleased to be able to have you on today. And our next part of our event is a break. All right. Hopefully folks are coming back from their break. I'm going to keep us rolling into our grassroots panel discussion. As Veronica introduced earlier, we have some great grassroots advocates here to talk with you today. Our 2025 Advocacy Committee Chair will be moderating a discussion with Starlin Hayden Greeting, Cindy LaFond, and Jessica Von Gohler, who have all had years of work with various states in Medicaid advocacy across PBM reform, that's pharmacy benefit managers, and the DPP. And so I'm going to have them all get spotlighted. I'll pull my slides down and we will get started.
Okay, so we have 3 individuals who've chosen to make a difference for others through their statewide efforts and nationwide through advocacy. They're going to share their stories with us. I've heard them, they're really good, so I don't want to take up too much of your time. Starlin has dedicated over 45 years to advancing pharmacist and team-based care and diabetes care through advocacy, education, and public health leadership. Through active membership and leadership roles in both ADCES and the Illinois Pharmacist Association, she has championed many national efforts as well as efforts to secure Medicaid reimbursement for diabetes services and diabetes technology. Starlin continues to drive PBM reform and health equity initiatives. And she's going to talk to us about PBM reform. Following that, Jessica Von Gohler is a volunteer advocate and DPAC champion dedicated to PBM reform and equitable access to insulin. Living with type 1 diabetes for 50 years, she brings a powerful patient perspective to policy discussions and has supported recent Massachusetts legislation to increase PBM transparency and reduce insulin cost. And then following the PBM reform discussion, Cindy LaFond serves as the Executive Director of Health Interventions for the Granite YMCA, where she has dedicated over 30 years to advancing community health and wellness across New Hampshire. Granite YMCA has many evidence-based, sustainable, reimbursable programs to promote mental and physical health, addressing chronic diseases. She is going to share her experiences in bringing the diabetes prevention program to the YMCA. So each panelist has about 5 to 6 minutes. Starlin, would you begin for us?
Sure. Can you hear me? Just wanted to check because can you hear me?
I can hear you, but your video is a little frozen.
Yeah, let me take off my video. Okay. So I'm a pharmacist, pharmacoepidemiologist who has, after completing my healthcare and public policy fellowship with Senator Paul Simon, I have, as you heard, I have over 2 decades Medicaid. This all needed to happen. All these steps needed to happen to move everything forward. So I served on multiple Illinois state health collaboratives since 1990 to bridge the administrations as new governors and new administrations came in to keep chronic diseases on the radar, especially diabetes prevention, control in front and center. What's important to notice is when I started this, we didn't have a PBM problem. It's after we start becoming more electronically involved. And so in Illinois, we learned very quickly that policy only moves when everyone shares the table, meaning we got some grants from the National Association of Chronic Disease Directors. That's my CDM is through them. The Illinois Public Health Institute and HFS and Medicaid and public health departments had to be involved. The medical societies all needed to be involved, and ADCES, AADE at this time, ADA, ACE, the Kidney Foundation, all the colleges of health professionals. It took a massive stakeholder group to team together and develop a diabetes state plan and align all of our funding and metrics and provider voices, because the common issue that brought us all together was the cost of medications for people with diabetes. And when we brought everybody together, we found out that the process of Medicaid receiving rebates from drug companies in order to have their drug on the formulary spread out into not only the Medicaid payer system, but it spread out into the commercial payer systems. So let me just quickly give you a generalized pharmacy benefit definition. Pharmacy benefit managers, PBMs, are third-party administrators of drug benefits. Their primary roles are to process pharmacy claims, because it was when we started online claims processing, we started with pharmacy first. They were data buses. Ross Perot owned most of them way back in the old days. And so these data buses were just supposed to take claims from all the individual pharmacies and hospitals and systems and pass them through to the ultimate person who was paying for the benefit. Then they grew into being benefit administration. So they became a gatekeeper where they controlled what medications and created the formularies, and they served the insurers, employers. If you're a self-insured employer group, unions sometimes negotiate with a particular PBM to get their union members a kind of a deal, and then government programs. But PBMs, in essence, control the formularies. They generate the rebates that they take from industry, and that establishes the pricing. And there's very little transparency, and they quietly decide what our persons with diabetes or any persons with any conditions, what type of medications and now devices are accessible to them. The big three are CVS Caremark, Express Scripts, and Optum Rx, and they control over 80% of the United States pharmacy claims, prescription claims. So their decision directly impacts our patients with medications that are covered and how quickly they receive those. So some have step programs where you have to step people through the lowest and go to the highest, so forth. And you heard a great deal of that already from our experts that we've listened to about maintaining that access. So one of the longest fights I've ever been part of is the pharmacy benefit management reform in the state of Illinois. It's taken us 26 years, and we've developed it over 4 different bills, 2 major bills. The most expansive bill we just passed and the governor signed on July 1st of 2025. And it was bipartisan coalition of physicians, pharmacists, health professionals, patient advocacy group, health systems, everybody got involved, and the legislation really got involved because we were very concerned about where the costs were going, because we lost over 200 pharmacies because of the PBM clawbacks. You'll hear the word clawback because the pharmacy will buy a drug for $50 and the PBM negotiates with the industry people to get a rebate for them that's not sent down to the patient or to the employer, and they keep that money, and then they take another $10 back from the pharmacy after it's paid for. And so the pharmacy, while they paid $50 for the drug at the wholesalers, they're only getting reimbursed $40, and then there's the patient's copays. So it's in the last 5 years, this has become more on target. So one thing that what these experiences taught me is that collaboration is not optional. It is the glue that holds policy, practice, and patient outcomes together.
Thank you, Starlin. Jessica, would you share your experiences?
Sure. So I'm Jessica Von Goller. I've had diabetes for 50 years, which is long enough to still remember 2 drops of urine for 10 drops of water for home urine testing. And maybe you get a good reading and maybe not. So that kind of leads into my advocacy because that really stunk trying to do that. And it started the day somebody told me that, no, you can't do that. You have diabetes. The first time I heard that, I was 4 years old. And every time I've heard no sense, it just lit another spark and I just kept fighting. So I learned how to focus my spark and fight through my parents. They were probably the best advocates I know. They didn't have medical degrees, they didn't have a roadmap. What they did have was a parent support group through the American Diabetes Association, which was led by one patient and I believe one parent who just wanted a better world for the next generation with kids with type 1 diabetes. These two, Paul and Marjorie, showed my parents you just need conviction, right? You don't need a degree. You don't need to know how it works. You just need to have that conviction. So they essentially turned my completely terrified parents into advocates, and then in turn, I learned from watching from them. So, professionally, my world has always been about building bridges, which ties directly into advocacy. I build these bridges between science, operations, and people as a biotech project manager, helping to bring cell therapies from the lab to patients. That is the instinct that drives my career, is the same one that fuels that advocacy work. Um, I can I can say, and I'm slightly proud of my accomplishments, and I'm going to try to be humble. Um, I've I've done some things that I never imagined possible. I was the first person with type 1 diabetes to earn a U.S. Coast Guard license to be able to work in engine rooms for tankers and cargo ships. And to me, this milestone isn't about the credential because there were several other credentials that had to come before that. It's just the proof of what advocacy, education, and persistence can make possible. And that persistence, I am feeling it with the PBM fight. So, to, so today I serve as a Diabetes Patient Advocacy Coalition champion advocate. I am actually going to DC next week. I hear everybody's there and working. And the topics that have been discussed today are the very ones that we will be covering. And I'm also leading the rollout of grown-up type 1 diabetes of Greater Boston, which serves midlife adults with diabetes just looking for a community connection. So that's the other piece I bring to this. And I'm here hoping that I'm able to demonstrate today that we each have a platform. If it's a clinic, a kitchen table, a state house, agency, it doesn't matter. As long as we use it, change happens. So that's my deal.
Thank you, Jessica. So those were both PBM reform advocates. Our next panelist is going to talk to us about diabetes prevention program and how she managed to bring that to the YMCA.
Thank you very much. So to make sure I get everything I wanted to say and stay focused, I wrote all mine down as Hannah guided me to do. So that's what I'll be doing. So for more than 30 years, I've had the privilege of serving at the Granite YMCA, where I currently lead our health intervention initiatives. Over the years, I've witnessed how the Y can transform lives, not only through fitness or youth development, but by becoming a true partner in community health. In my role as the Executive Director of Health Interventions, I help lead statewide efforts to prevent and manage chronic disease like diabetes, hypertension, arthritis, and cancer. When I first started, I couldn't have imagined how powerful the YMCA could serve as a bridge between healthcare and the community. But that's exactly what has happened here in New Hampshire. Through programs such as the CDC's National Diabetes Prevention Program, the Diabetes Self-Management Education and Support, blood pressure self-monitoring, Live Strong at the Y, Enhanced Fitness, and Tai Chi Quan Moving for Better Balance, we've built a network of support that reaches across all 10 New Hampshire counties. These programs don't just improve members or numbers on a chart, they restore confidence, health, and a connection for thousands of individuals and families. Our goal has always been a simple: to make these life-changing programs accessible to everyone, regardless of their insurance, status, or financial situation. That vision has guided our work with hospitals, federally qualified health centers, insurers, and state agencies to align programs, streamline referrals, and create sustainable systems that truly meet people where they're at. One of the efforts I am most proud of helping is to advance New Hampshire's Medicaid state plan amendment to include coverage for the YMCA's diabetes prevention program. The amendment established language stating that each managed care organization, MCO, shall develop and implement evidence-based wellness and prevention programs for its members. MCOs should seek and provide wellness and prevention initiatives aligned with similar programs and services promoted by the department, including the National Diabetes Prevention Program. While this language created an important foundation for coverage, it did not explicitly require MCOs to contract with community-based providers like the YMCA. As a result, we've been working directly with each MCO to develop individual agreements and ensure that their members have full access to these evidence-based programs. I would share we have been able to work with them for programs around prediabetes, diabetes, as well as arthritis and fall prevention programs and blood pressure self-monitoring. These efforts represent both progress and persistence. We have moved state policy forward, and we continue to build the operational bridges necessary to make that policy real for people who need it most. As a result of these collective efforts, the Granite YMCA is now recognized as both a Medicare supplier and a statewide and multi-state umbrella hub, supporting YMCAs and partners across counties. Together, we're creating a unified system of care that helps people prevent disease, manage chronic diseases, and live longer, healthier lives. On a personal note, I've seen this work come full circle. I've watched participants who began our diabetes prevention program lose weight, reverse their prediabetes, and regain their energy. One participant told me recently, "I came to the Y because my doctor told me to. I needed to make a change. But I stayed because I finally felt supported." That's what it's all about, creating a place where people feel seen, cared for, and empowered to take control of their health. For me, this isn't professional work. It's a personal calling. I believe health begins where people live, learn, work, and play. And that's where the why makes its greatest impact every single day. Thank you.
All right. Well, we appreciate that excellent information. I think these ladies have shown that advocacy can take many different forms. You don't have to have a particular background. You can stand up for things that you realize are right and achieve positive outcomes that benefit many different people. So we are going to have a Q&A time for this session. So if you would like to put questions in the chat, we will address those shortly. We're going to start out with a few questions that they've kind of prepared answers for, and then we'll get to your questions as we go along. So the first question, and I know some of this was addressed as you went along, but you may want to contribute some other information. You all mentioned various collaborations throughout your advocacy efforts. Could you each talk about the organizations and people that you worked with through this? And can you talk about how those groups came together and what that looked like in your advocacy efforts? And for time purposes, we'll just go in the same order. Starlin?
As I said, we started working on the state plan, diabetes state plan, and we didn't realize that we didn't know what we didn't know, if that makes any sense. So we started as a small group of mostly diabetes care and education specialists, and then everybody was supposed to bring a friend and a friend and a friend and a friend, so that before we were able to work with the Institute to work toward getting Medicaid to pay for DSME and DPP, and also to get a framework around the PBM impact on our access to care through medications or technology, this group built into this very large stakeholder group, which involved all the professional organizations, all the government agency representations. We let industry come. We had an industry subcommittee that talked about and teased out and helped get a lot of the details. And so we worked in these small work groups, and then once a quarter we would pull the information together. And when we identified the fact that DPP was probably the first to get started on the diabetes roll. That's why the Illinois Public Health Institute kind of took and the pharmacy world, we all took because it impacted the loss of our pharmacies in the state and across the country.
And I believe we've lost her. Jessica, would you like to answer that question?
Sure. So I had an answer prepared, but I think I'm going to change my answer. During COVID, I think we are all very well aware of the challenges for people with type 1 diabetes to be recognized as a priority in getting the vaccine and access to treatment. So I got a little upset, started a petition when Massachusetts wouldn't budge. And at the end of 2 weeks, I had 20,000 people who had signed the petition trying to get Massachusetts to change the rule. Because we were going in with the general population fighting for, what vaccines there were. What it turned out to be was a bunch of smaller partnerships, whether it be with the media, because the media was fantastic. They promoted everything for me and interviewed me and re-aired it and put it on all their other pieces. So I had a good story, a compelling story for them to keep saying over and over that was relevant. And that was a critical piece of collaboration. But then there were all these community groups. I learned that there was an online diabetes meetup for Massachusetts. They tried to meet once a month, but it was a little hard with COVID, so they moved online. But they were able to help me get the word out. And so, and even some of the bigger organizations like the Diabetes Patient Advocacy Coalition said, hey, the state's working on this, or this reporter needs that. So the access to other people working on the same thing mattered. And in the end, it turned out it wasn't really about who was leading what. It's that we all had the same goal, and it was making sure that our voice and where we could contribute added momentum to keep moving it forward. And as you saw, as more states said, hey, type 1 diabetes is a priority, eventually the efforts on the federal level kind of combined with that sort of pushed everything through for everyone. So it's that, to me, it's sort of the collaboration is the heartbeat of moving things forward so you can take all the steps in sync.
Thank you. Cindy, tell us about your collaboration efforts.
Great, thank you. The one that comes to mind most was during 2021, right? As we heard Jessica say, the pandemic was going on. We were rolling out our diabetes prevention program, enrolling participants. And it wasn't long during this process that we were discovering that many of the folks that were coming for our program had type 2 diabetes. But they wanted to be at the Y, either with a family member, with their friend. They want to be at the Y, right? Socializing, interacting. So thought, hey, what do I do next? So I went to the state public health and Marissa and Emily there and said, hey, what's the opportunity of a Y becoming accredited with an organization like ADCES for diabetes self-management? And I still have this email that was sent to me in big capital letters that said, yes, yes, we will help you. And that started so many exciting things to happen. But it took us about a year to get all the team players we needed, get everyone involved. And I wanted to be accredited before the end of December of 2021. And December 30th, I got a message from ADCES that you have been approved and are now an accredited diabetes education organization. That just was so exciting, but it brought on so many other partnerships in our state. All of the healthcare that we're delivering diabetes education, they didn't think I was a threat. They thought we could support. We could offer that social area. We could support memberships. We could support physical activity. But it brought so many groups that we weren't talking, got us to talk, and actually will share got me to present at the ADCES that a Y could be a partner among this work. Thank you.
Okay, Starlin, did you have anything else you wanted to add? I know you kind of got cut off.
Yeah, I'm sorry, there's construction going on down the street, so I think it's impacting. I can pick up more onto the second question.
Okay, so let's go ahead to the second question. In the area of advocacy you have the most experience in, how could the voice of the DCES contribute to moving these policies forward? Starlin?
So the diabetes care and education specialist's voice is the most powerful because it serves as a bridge between our patients, our people with diabetes, and the policymakers. So sometimes the people with diabetes can't take off work and go and advocate, but we have all the stories because we share their stories while we're meeting with them in what capacity that they're meeting with us in, either in the prevention or in the DSME or in cardiometabolic care, and bringing those stories and pairing that with the science that we all know helps get those across. Legislators hear numbers and dollars and statistics all day long from a multitude of diseases. But when we put that story with what the need is, with what the outcomes and the capacity is, then it starts increasing that explanation, and then they understand better. Around our PBM bill about decreasing access with our patients with diabetes helped move things over in this current administration in Illinois. Our governor has struggles with weight management, and he's talked about it. And when we talked about how PBMs were making it so unaffordable for our insulin and our medications to treat diabetes and cardiovascular issues, that's when we got them to sit down and audit what actually was going on. And that audit, along with the fact that we had just passed the DPP and DSME, it's like it was a perfect storm. Does that make sense? That the real world evidence met up with our documentation and our patient outcomes, and mostly our patient stories. So I can't emphasize how much finding someone in that legislator's backyard coming forth and helping you tell that story and supporting them. We can be the science, and they can be the heart.
Excellent. Jessica?
Sure. So when I think back to the two people that mentored my parents, that then it spread on to me and the other people, there weren't diabetes care and education specialists back then. They were the version of it. And I think about how powerful they were, and how potentially underused they could have been in other places. Um, but but what they were seeing was, gaps in coverage. They were seeing limits and blocking of care. They were seeing kids who were being told you can't play soccer. And they were hearing these stories over and over and over again, and they were able to share them in bulk. So nothing is as powerful as a personal story to a legislator. But when you go in and you say, look, I've got 6 patients who can't get insulin in their rationing, then, and add that story to it and your experience and how you feel, that becomes something that these decision makers are able to increase their awareness and make an action. So it doesn't really matter if it's, somebody in one of your clinics, or a one-on-one with a patient, or a conversation you have in the hallway. I have found my daughter is on a swim team. I have lots of conversations with their parents, and the amount of information I get, I'm able to just turn that around, and say, hey, I know another mom who's a swim mom who has diabetes, and we both have this problem. And it makes all the difference when you have the numbers. So I would say
Thank you.
your voice.
Okay. Cindy, how can the voice of the diabetes care and education specialist contribute to moving policies forward?
I think of the Ys, and if I think of New Hampshire, I'm thinking that there's 13 Ys, there's thousands and thousands of members that are in our building. And I will share, when we started to promote that we were accredited with ADCES for diabetes, I cannot tell you how many people came up to us and took their hat off and shared they had type 2, they had type 1 diabetes. We are actually getting children who want to go to camp at a Y and are saying, I have type 1 diabetes and I want to go with my friend at the Y. So they feel that when they can open their voice and share their story, they feel that the Y now is a place that can support their whole health. And I think that's going to be a huge advocate to get ADCES and others to really advocate for folks to be where they're at and be able to play and have fun with those they want to.
Thank you. So, Hannah, do you see any questions that I'm missing in the chat?
I don't see any yet. I just prompted folks to put some in. So hopefully they come in. I have a question though. I want to circle back to Jessica's story. And I know when we were talking and prepping for this panel, you talked about some testifying you had been doing. So would love to hear your experience actually testifying in front of your state house. That's often an activity that ends up happening if you're having to go the legislative route for something. And I know you have a wealth of experience doing that. So we'd love you to share that with the group.
Sure. So I find working with my legislators is a number of different ways. Most recently, I testified for PBM reform in Massachusetts. Was recovering from knee surgery. I was able to do that virtually. I think the hardest part of it is you have to put all your points, so in my case, 50 years of points, into 3 minutes. So ChatGPT becomes your friend, saying, how do I boil this down to 3 minutes? The good news is you only have to fill 3 minutes. So it's rather easy. You can do it remotely, you can do it in person. I had previously worked on another bill related to pharmacy benefit managers in Massachusetts, and I went in person. And you definitely have that feeling of people are engaged, they're listening to you, they want to hear your story so that they know how to represent the people, which I know is very different than some of what we're experiencing right now. On a smaller level, every time I get a thing from my insurance company saying, we want to see if you'll do all right on metformin, you really probably don't need insulin. I just pick up the phone and call my state rep. And, he picks up the phone and calls somebody. Sometimes I get a hint, go talk to this agency, or I get I've called them, this should be all set. But it's at first it's intimidating, but it's very easy. Now, when I call them, I get a text back saying, hey, I saw you called. Is it your pump or is it insulin this time? So you start to build those relationships and it becomes easier to share those stories and have that impact. Did that answer your question, Hannah?
Yeah, I know that can be a really intimidating thing for folks to do. So I wanted everyone to hear about what that looks like.
And the first time I did it, I was 5. So if anybody needs to say, she did it when she was 5, I can do it as an adult, use that.
And
We
these
have a
ladies
question.
have shared big efforts where they have had leadership roles. They've testified and they've initiated things and they've brought together other organizations. But there are easy things with advocacy that each person can do. Maybe you're not ready for such a big role to start with. ADCES does a great job with the website, keeping us up to date on policies, any kind of advocacy efforts in the works. And they make it really easy. You can just put your information in and they will populate a letter to or an email to your legislators. You can send as is or you can personalize. So a lot of different things with that. Advocacy is for everybody. And we may have a small voice, but when you combine everything, it's a large voice. So any last words, ladies? Any last piece of advice?
Well, I'll start off. You don't need a title to make a difference. So every phone call, every email, every written letter, when I was on the inside, everything that came through the mail was stamped and tagged and it had to have a response. So there's more of a response in a written letter sometimes than our emails, but the emails get their attention and then write them a note to their local office to enhance that email that you sent them. Join your state professional associations and your national associations. They want to know if there's a PBM reform lobby. There is. I serve on a joint commission on government affairs for healthcare that involves the Pharmacy Association works with ADCES, works with the dietetics associations, works with the medical associations. We're all in this together because we all have patients in common that are terribly being impacted by the undersupervised pharmacy benefit managers out there that have been wild westing the middleman and making lots of money. So you have the ability to know it. When you have an issue that your patients have or you have, talk to a pharmacist, and the pharmacist will talk to the pharmacy lobby person, and we can use that as an example, because that's just it. What happens is we'll gather the data and the stories, and then the PBM lobbyists will say, oh, that doesn't happen. That's just a one case scenario. But what we've been showing them in these audits of Medicaid, state Medicaid Association, is how much of our tax money is being sucked up into the pharmacy benefit managers and not passed on to savings for the patients, not passed on to the employer process, and not really using the best practices to choose the delivery methods that we're using. So your voice matters, and we're all working together. And you're going to hear more about this later.
Jessica?
Yeah, I would have to say anytime somebody comes at you saying, I can't, I have diabetes, or they won't let me, I have diabetes, turn that into watch me. You can't get an insulin pump because you haven't had diabetes long enough. Watch me get it, and put up that fight for sure. There was a college I wanted to go to that told me I couldn't go because I had diabetes. My answer was watch me, and I went. So I think that's the most powerful thing you can do for someone with diabetes is turn that I can't or you can't message into a to watch me
Perseverance, definitely.
every time.
Cindy?
I was just going to say, if you need someone to stand behind you, there are Ys almost in every corner of this country. I would reach out. They're really passionate about standing by, supporting that, and that's where many folks are hanging out. We're there to help and support.
Thank you. Also with the website, I did appreciate Hannah including how you can look up your state legislators in case you don't know. A lot of times we don't know the best way to approach Medicaid about a particular thing we want. And sometimes the best bet is to find your legislators, go through them, and sometimes they can put you in touch. The Alabama dietitians have had that experience in the last couple of years. One of my state legislator was able to put us in touch and arrange a meeting with the leadership for Medicaid. So we were able to get our foot in the door with that. So there are different ways you can go about doing this.
We had a question that I think Starlin saw in the chat about who is working on PBM reform. Our speakers from DPAC and DLC are talking later. Jessica, I know you work really closely with them, so maybe you can tease that presentation a little bit, and that can be our segue.
Sure. So one of the things that is near and dear to DPAC is PBM reform. And they are, in my opinion, the experts in this. But they got behind Patient Pocket Protector Coalition, which is not just diabetes, it's all sorts of chronic illnesses. And it's very specifically to address the PBM rebates. It's a great starting point and a place where you get more information. I did drop the link in the chat, so it should be easy to find. And I would say, oh, I just opened up the site. The numbers of who's supporting it has even grown since a couple days ago. So so they're valid.
Thank you. Janet, any last words?
Ladies, we just appreciate your time, your experience, your example. And everybody else, just make a plan. Make a plan. You're going to do something to advocate this year before the year ends. So we'll turn it back over to you, Hannah.
Thank you. And thank you all so much for being here. Really appreciate what you have added to the conversation today. Well, I want to make sure that we stay on time. And we have our friends here from DPAC/DLC, George Huntley and Aaron Callahan. I assume one of you is sharing your slides, but if you need me to,
Be
let me
delighted
know.
to do that. And glad we're having this chat. So let me actually have the slideshow be a slideshow
That'd
since
be
we
great.
moved from one place to the other.
Yeah,
Hi, everybody.
And
great. And we can see and hear you both.
awesome. And it is great to see so many friends on this call. This is really great. I guess we should start with introducing ourselves, Aaron. What do you
I'd love
think?
that. Yeah. Take it away.
I'm George. So I'm George Huntley. I'm the CEO of the Diabetes Patient Advocacy Coalition and the Diabetes Leadership Council. And I am also very honored to be the board elected director on the ADCES board. And I'm thrilled to be part of this organization. Loved it forever. Patient living with type 1 since 1983. I have a sister, niece, and great nephew also with type 1 diabetes, in case anybody thought it might not be in the family. Apparently it is. And I am also a past national chair of the American Diabetes Association. But germane to this conversation, most of my career I've been a finance guy. And in the finance world, I was a financial officer of services firms and manufacturers, and was the plan administrator of our employer-based health plan for 25 plus years. And when you get into how the money flows and how this all works, it's all about money, in case anybody hasn't shared that with you. So we're delighted to be here and talk. And I'm going to let Aaron please introduce yourself and all this. And I'm in Indianapolis, in case the Bears didn't look like they were from Indy.
Well, I'm from Chicago, the home of the real Bears. Great to be with you all. I'm Erin
Great.
Callahan. I'm the Chief Operating Officer of the Diabetes Leadership Council and the Diabetes Patient Advocacy Coalition. George is going to share a bit more about who we are and what we do, I think on our next slide. But I don't have as many distinctions as George yet. I also don't have as many family members with type 1 diabetes, possibly yet. I hope not. But I've been in the diabetes world for about 10 years professionally, and prior to that, as a longtime volunteer, and prior to that, as a camper, and prior to that, as a newly diagnosed 6-year-old in 1986. So I've been living with type 1 diabetes since the days of 4 finger sticks a day. My aunt would come to my grade school, since the days of a gram scale in everybody I knew's kitchen, since the days of the exchange diet, if we could date ourselves back to then. I did have one of those urine testers that got super, super hot on my 6-year-old fingers, but I came about in the time of the AccuCheck 2, which took a blood sample about the size of a shot glass and required 2 whole minutes if you didn't create an error. So the fact is, so many things have changed since 1986 when I was diagnosed, and just shortly before, when I know that George was too. And we want to make sure that policy is keeping up with all of that progress. To the surprise of no one, there have been a few hurdles, and we have some particularly challenging contenders in the policy arena. And George and I are going to talk to you today a little bit about what states can and should be doing about pharmacy benefit managers. George, share a little bit about who we are.
So the Diabetes Leadership Council and the Diabetes Patient Advocacy Coalition, these are affiliated organizations. Aaron and I staff both of them. DLC is a 501c3, which is a normal charity to the extent that any of us think we're normal people, but I think we're a normal nonprofit. DPAC is a 501c4, so it's a separate entity. DLC is the policy shop. Everybody on the Diabetes Leadership Council board is a past leader of a national diabetes organization. We've got centuries of diabetes experience and advocacy experience, and we go through the policy, and we work closely with everybody in the diabetes community, and very especially close to Hannah at ADCES, and value strongly our partnership. DPAC is the grassroots army. Being a C4 means we can lobby. And so when all we do is advocacy, the only thing either of these organizations do is advocate on behalf of people living with diabetes for accessible, affordable care for anything a patient needs, type 1, type 2, gestational, you name it. And we look at because of the economics, we look at the entire healthcare infrastructure, including making sure that a patient has access to DSMT. And those kinds of things. So That's where we've got two organizations, DPAC can lobby, DLC can do the policy work, and we work together pretty well. And now we're going to talk today about these PBM things. And by the end of this conversation, if you're not pissed off, we haven't done our job.
That's fact.
So I'm convinced, I'm confident. Some of you already started that way. We're just going to reinforce those feelings. So if this is not a feel-good presentation, in case just a spoiler alert, but we're going to talk about the impact of rebates on cost and access. We're going to talk about prior auth, step therapy, out-of-network pharmacies, pharmacy deserts. That's not desserts with ice cream. And we're going to talk about specifically, and some really great dialogue has already happened on this, and how a DCES can help, how your role in this whole picture works. And you can make a massive difference, but it's not for the faint of heart. We just in a breakout session. Hopefully, you had great breakout session conversations. Advocacy is a long game. I started when I was very young, and I'm still doing. I'm joking, but it's a long game. So why don't we dive in, Erin, and take us away on PBMs?
Yeah, so we're going to make you work for it a little bit. I see that the chat is active, which I love in a conversation. And also, y'all know how to use your emojis. How many of you do not know or have not heard of a pharmacy benefit manager? And I'm going to give a couple of seconds to let that question hang. Okay. We're going to tell you all about it. You're in the right place. But it seems as though the pharmacy benefit managers in the word cloud of life have come into focus and in a bigger space, in a bigger font, a little bit more central to a lot of the conversations, especially around policy. And George and I have both been doing this for a while, even with legislators, rather. Lorianne, thank you for that. Even with legislators, they didn't really know what a PBM or a pharmacy benefit manager was maybe 5, 6, 7 years ago. We had to explain their role. We had to explain what they do. We had to make some corrections to some misconceptions about who actually benefits from the pharmacy benefit managers. And we're going to talk a little bit about that too. Starting with rebates, in particular, that is one of the things that we at DPAC especially, and certainly with the support of DLC, have been fighting against. And we're going to share some shocking rebate information with you shortly. But other things that PBMs do are often referred to as utilization management practices. And these are things that impact such issues as step therapy or fail first. Why does anybody have to fail anything first? Certainly. Also, prior authorizations. I think we could collectively burn down the house with our issues with prior authorizations. They also work on behalf of their owners in many cases, or their clients, which are payer organizations. Those are health insurers, of course. And they try to negotiate the best price for the payer organization. George.
And the key here is this is the state conversation. This is the hottest issue from a healthcare perspective at the state level that we've encountered in a long time. To Erin's point, 5 to 6, 7 years ago, we had to explain what a PBM was, and go through that. 1,200 state bills this session across all 50 states. They had bills doing something on PBM reform. That is the very definition of hot. I guarantee you there will be something in your state. Now, I'm lying to somebody in one of the states, so that's when I say I guarantee you. But strong likelihood that there will be a PBM reform bill in your state. And it's really coming, and it's hot at the federal level. We do have to address this at both the state and the federal level. In case you say, oh, if the feds do it, do I still have to do it at the state level? You kind of do, because the feds deal with Medicare and a little bit of Medicaid, but it's really Medicare and federal plans, and ERISA plans, which are self-insured employers. but the states deal with the state level plans and the exchanges and things like that. So you often have to pass a law in both places. The point here is this is hot, 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 and hot. Aaron, talk us through the insulin side.
Sure. I wasn't quite there yet, but we can get there.
Oh,
No
sorry,
problem.
but
That's okay. As I was saying, the pharmacy benefit manager is responsible for negotiating the best price for their client. And to be clear, their client is the health insurance plan. When I say the best price, I mean that's the one that's the most beneficial to them. That does not necessarily mean that it is the lowest price available. And this slide is the one that will make you mad if you didn't start that way. But we've heard about the rising cost of insulin for many, 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 many years. Things have tapered a bit in the last couple of years, thanks to a lot of legislation and due to a lot of pressure from elected officials, encouraging manufacturers to reduce their price. What they did not yet come to the realization of, and there are lots of bills at the federal level, just as there are in the state level, looking to address PBM reform, is that pharmacy benefit managers are the ones that actually negotiate the price of the drug from the manufacturer. The payer organizations, in concert with the pharmacy benefit managers, also determine the price to the customers or to the patients or to the folks that we are all privileged here to serve. Since 2012, the list price, which is the general top price of insulin, the one that patients are responsible for paying at the pharmacy counter, increased by 143% through 2022. In that same time, the net price, or the price that the pharmacy benefit managers were actually paying, the price that the manufacturers were actually receiving for that same product, reduced by 54%. That's a spread of nearly 200%, and that went directly to the pharmacy benefit managers. And the reason for this is because of the rebate system. In order to vie for placement on formulary, the pharmacy benefit manager negotiates with the manufacturers and on what is the best price for them, or the price that's going to make them the most money, because ultimately they have a responsibility to their shareholders too. That means that in some cases, if the manufacturer cannot drop their price any lower, what they will negotiate is a rebate, saying you can establish your price higher, but we want you to give us a rebate down to this price so that we're actually pulling money out of the system. Where that money is not going is to benefit patients. And one of the goals of DPAC and a coalition that we started called the Patient Pocket Protector Coalition, of which ADCES is a proud member, we thank you for that, is to ensure that the rebates go directly to the patient at the pharmacy counter.
Patients should be paying this net price and not the list price. And we've got that law passed in Indiana, West Virginia, Arkansas, North Carolina. I'm going to miss one. New Mexico, I believe. Yeah. Yes. So we're working very hard on that. Why don't I take us through what we used to call the hairball, as to how things flow, because it's all about following the money. So let's start with the patient, which is the consumer. And the consumer has paid a premium for access to the plan. The way I like to say it is you've paid Sam's Club dues, but you're not getting Sam's Club prices. You're trying to join Sam's Club, which is your health insurance plan, but you're not necessarily getting the plan benefits. You go to the counter at the pharmacy in January, and you're paying full list price. You're paying this red price, and you're not paying this low net price while you're in your deductible. Once you get to your copay, you're paying $30, $40, whatever that might be. One of the questions that we wanted to ask you is how many out there are seeing a problem with the price of insulin for their patients today? We've made a lot of progress on that, but it's not fixed on commercial plans. If you thumbs up or whatever, if you're having issues with the price of insulin in 2025, I'm just curious as to how prevalent that is. It used to be the number one thing we spoke about. I'm seeing a couple of responses on that. So but what it is it's not everybody. So we've made a lot of progress on the cost of insulin, which is fantastic. But this this system that we're describing is every single branded drug out there. So if your patients are on Jardiance or Farxiga or pick anything else, they're having this same issue is there. So you're paying list price during your deductible period, and the pharmacy is buying the drug from a wholesaler, and the money eventually gets either from the pharmacy or the wholesaler to the drug company, and they're getting list price, and they're sending that rebate down back to this PBM in the bottom red. That PBM now, the average rebate is 48% on a branded drug. In insulin, it's much higher. So the PBM's getting 48%, about half of the value kicked back to them. And I use that word because it is exactly what it is. It's a kickback to the PBM for access to the formulary. Because otherwise, you wouldn't at the cash register be even able to buy that drug. It would be outside of your plan. Your plan would have excluded it. The PBM is keeping a portion of the rebate and sending it back up to the health insurance company, self-insured employer, fully insured if there's an insurance plan, the government if it's a government plan. The important piece is they're keeping a percentage of it, which is why they have an incentive to put the highest priced drug on the plan, because this split, this delta here, that in between, that's where they make their money. And they don't actually care about this level. They care about this gap. And so a lot of the advocacy going on in PBM reform is about delinking their revenue from this list price and the price of the drug and getting it down to, you should just get a flat fee for processing the transaction. Thank you very much. And you're doing something that's necessary, but you shouldn't be making a profit off of it. That's creating a barrier to access to other things. So the PBM is keeping a piece of it, and they're sending it up to the health plan, the balance of it. In a second, I'll talk about why how much they're keeping doesn't really matter. But again, the consumer has paid a premium to get access to this, and they've got no benefit from it until they finally met their deductible. Now, if they went to the hospital, if they go to a doctor, actually, if they go to see you guys and have your services done, they would actually get the plan discount for the DSMT, the services, the labs, whatever it might be. They immediately get that discount. They still may be responsible for paying that net amount after the discount because they're in their deductible. But in drugs, it doesn't work that way. And in drugs, that discount, it all flows through after the fact unless we force it to go the correct way. And then the health insurance company will say, I'm using all of this extra rebates that I'm getting, because if you just spent $600 for a drug, and let's just say an average of 50% rebate, the health insurance plan just made a $300 profit because you went to the pharmacy in January. That's crazy. So you have the sick subsidizing the healthy, and they're saying, I'm using all of this money to keep the insurance premiums down for everybody. But again, you've got the sick subsidizing the healthy. That is reverse insurance. That's not how it's supposed to work. So we're trying to break that process by delinking the PBM's piece of that rebate and making sure that it goes through to the patient. That's what PPPC is doing. And we've got it done in a couple of places, but it's a long way. The other piece that happens here while I'm on this slide is the PBM is then reimbursing the pharmacy for the drug. So, because the pharmacy paid for the drug, and they're really not keeping this money that's coming through from the consumer, they're getting paid by the PBM. And we will, in a few slides later, talk to you about how horrible that is working, because they're reimbursing pharmacies at different levels, and pharmacies are struggling in that regard. So, but before we get to pharmacies, let's stay with this, how much is the PBM keeping? And well, it really doesn't matter in many cases because the PBM is owned by the insurance company. So the vertical integration that has happened in the healthcare arena has been amazing over the past decade. PBMs, the top 3 PBMs are OptumRx, CVS Caremark, and Express Scripts, which have some affiliations. These 3 are about 80% of the US drug market. So they have a massive command of it. This whole slide is about 90% of the US drug market. And there are dozens of other PBMs out there. They're all small. They're actually the ones they should be using. OptumRx is a wholly owned subsidiary of United Healthcare. I'm sure we've all heard of them, right? And by the way, they have their own specialty pharmacy and provider services. Aetna and CVS Caremark and CVS Specialty are all one big corporate family under CVS Health. Cigna and Express Scripts, this is all. So if OptumRx is passing 100% of the rebate through up to the insurance company, it's still staying in the corporate family. It didn't, I'm not moved by I'm going to no longer keep rebates. It's a shell game of money. And it is also why they are driving you, certainly in this arena, to their own pharmacies, because they own the pharmacies and they want you to go to the ones they own. That happens a lot on the specialty pharmacies in the mail order pharmacy arena. And in this, the Aetna side, they want you to go to CVS and not Walgreens or Walmart and the others. I get it, but it's not good for patients.
I want to address a couple of the comments in the chat. Jessica, you said blatant conflict of interest. We agree. And Carol, to your question, is DrugRx a workaround that patients and clients are using? This is why the cost of meds are different at different pharmacies. I'm going to Tarantino this response. This is why the cost of meds may be different at different pharmacies. The cost of meds may also be different plan to plan. So for an individual patient, if you are on a CVS Aetna plan and you go to a pharmacy outside of CVS, you may be paying more because you're not going to a preferred pharmacy. Yes. My sister and I have different plans and we pay different amounts of money based on what our plan costs are and what pharmacies we may be steered to or directed to. And that's going to come into the conversation about pharmacy deserts and unfair practices later. With regard to DrugRx or GoodRx or Mark Cuban's Cost Plus Drugs, yes, these are attempts to disrupt the current system. They are in fact taking the place of pharmacy benefit managers and just delivering the lowest net price to patients in some cases. I know Mark Cuban takes a small percentage of each of those net prices, but people can go through that. Part of the problem with that is that if you are paying full freight for your insurance premium, that includes your drug plan, that includes your prescription benefit plan typically. And now you're buying your prescription drugs outside of your benefits plan. So a dollar amount that you pay, if you're using GoodRx or if you're using Cost Plus Drugs, or if you're using the recently announced TrumpRx, will go outside of your plan and you will not receive credit on your deductible for those payments.
Yeah. And I see a comment on GoodRx and Express Scripts are in bed. They are all PBMs. They're simply passing a piece of that through to the patient so you can get it a little cheaper if you're uninsured. Again, key is you're not getting any deductible credit for it. So you've paid Sam's Club dues and you had to buy it from BJ's, a warehouse. And you shouldn't have had to do that.
And Starlin, you're right about that. Starlin's got like PBM 301 on the brain. I love that. And Starlin, we look forward to seeing you and Jessica and some others next week at our DFAC Hill Day.
So when we advocate for rebate pass through to patients at point of sale, the other side, which is the PBMs, they tell you that, oh my God, it's going to drive up healthcare to the point where it's going to be unaffordable for everybody. Cats and dogs are going to live together and no one will ever be able to afford a medication ever again. And you wouldn't believe what it's going to do to the premiums. And the reality is it's a complete lie. And I have sat in so many, and Aaron has as well, so many state committee meetings where I am listening to this person say almost exactly what I just said. And they don't talk about cats and dogs, however. But the rest of what I said is really what they testify on. It is an absolute lie. So overcharging participants for drugs is false economics, you're going to meet your deductible early. I'm very proud. I have type 1 diabetes for 42, 43 years. Math's not my strength. I have a 43-year streak of meeting my deductible. I've done it 43 years in a row. I'm proud of that. Isn't that awesome?
Yeah.
If you overcharge my meds, I'm going to meet it early, and the plan's going to pay another claim it never would have paid. It's a complete wash. But in the meantime, you've inflated the cost of the drug and you've made it unaffordable in January and February and March in the first 3, 4, 5, 6 months of the year. And you've trained a patient with a chronic disease, your highest risk patient, you've trained them to ration their medications. Congratulations, that's the dumbest thing you could do. And so it's a wash. We have an actuarial study. It's less than 1 point on a healthcare premium. I passed through rebates to my employees for a decade. It did not raise the cost of my plan. In fact, it saves us money. But understand, you're going to hear that it's going to make things unaffordable. It is absolute smoke, and advocacy is about cutting through the smoke sometimes, and it will drive you bananas. But we're not going away because we know this math is right. It's just common sense.
So to George's point, I think we can go to the next slide. We've done a lot of work. I put a link in the chat to the Patient Pocket Protector Coalition, so you can see a little bit more about what we've done. And we have passed those laws in various states. North Carolina was the most recent state to require rebate pass-through at the point of sale. New Mexico actually had an initial law that we didn't love. And so we went back and said, make it better, help patients out. We had some great partners on the ground there. We had some really great clinicians that would advocate for us almost every single day on the phones and in person in the Capitol. And we were able to update that legislation to ensure that patients receive that benefit. And again, we want at least 80% of the rebates to be passed through to patients at the point of sale. Anything less than 80%, that's not going to cut it for us. But 100% may be a little bit challenging. And we found that when we speak in extremes with lawmakers, they get a little itchy.
Yeah, they do. So what about prior auths, Aaron?
I bet this group could tell us more about prior auth than even we know. I attended the ADCES Tech Conference last year and noted that it was standing room only in the prior auth session. So we look forward to more on that. But one of the things that we are doing at the state level is to monitor what prior authorization bills are being introduced. And we're going to be getting a little bit more deeply involved in 2026. In 2025, there were over 110 PA bills, including requiring insurers to respond to urgent PA requests, including putting time caps on how long a PA can sit without being referenced or addressed or responded to. We engage on policy measures that would establish an electronic PA process. We know that things are not getting easier in the mail. We are drowning in paperwork. You all are probably drowning in paperwork far worse than we are. And we know that the administration and administrators that respond to those PAs are not doing much to accelerate their processes. For any of you who have seen Zootopia, I think about that sloth who worked at the DMV all the time, especially with regard to prior auths, and I'm sure you feel the same way. There's also some federal legislation. It is the ensuring timely access to care for seniors that we and I believe ADCES have also weighed in on. But at the state level, this is something where we're really looking to partner with other chronic disease patient provider organizations to ensure that we're creating a steady pathway to these PAs, and in some cases, hoping to eliminate some of them for regularly issued drugs and devices, as we know in the diabetes space for sure.
And this is definitely a hot item. At 110 bills, that's hot.
Yeah.
The other one was 1,200. That's molten lava hot. But this is still a very hot topic, and I think it's going to get even more and more so. So as you're thinking about your local, chapter-based work, keep your eyes and ears open for that. And Aaron, I don't know if you're watching the comments, but that sloth is really popular.
Yeah, thank you. Now you'll think of it too.
Exactly. I'm going to have sloths instead of bears soon. Step therapy and fail first. I think this goes hand in hand to the prior authorization process because we all know how painful this is. And this is where they have a drug, they don't want you to take the one that's been prescribed. They don't make as much off the rebate. It's maybe expensive, etc. But the problem that's happening here and the problem that's happening in prior auths, but it's these things are linked. You get a patient, the turnover at companies, the current turnover at insurance. I've already been on that drug that you want me to go back on. And we're going to talk about some of this in the next slide. But I've already done this, and you're putting them through this. In the meantime, the patient has to go backward and health outcomes suffer. And we all know this. How many of you, by just show of reactions, because they're kind of fun, have this as a problem, as something that drives you bananas? So we can all commiserate. We got a couple.
Coming in hot.
Yeah, coming in hot. That's good.
All of that, George, to say, as I said earlier, why are we requiring people to fail first?
Yeah.
The language of it is bananas. The practice of it is inhuman.
Yeah.
It's crazy.
So this all gets back to the physician prescriber should prevail, a very simple patient advocacy position, and we've got to force this decision-making process to go quicker, and we got to protect the patients in this. So, Aaron, some protections exist.
Yes, that is true. Thank goodness. In many, many states. And there's a great group. There are many groups that are doing a lot of work on this to ensure that we are protecting people from failing first. That's the goal. I'm sure none of you decided on your career and your life's work because you wanted people to fail. Quite the opposite, in fact. And we're very, very grateful for all the work that you do. We have been working in concert with quite a few other patient advocacy organizations to ensure that we keep pushing for this step therapy legislation, whether it's a ban on step therapy or it is some sort of acceleration to the right product, to the product that has been determined to be the best one for that patient between the patient and their provider. Those are the decisions that matter the most, not a decision that's made either by a spreadsheet or somebody in a back office looking at a bottom line.
But I think it's fascinating to see how many states out there have already, if you're in the green, it doesn't mean that you're safe, okay? But it does mean that your state has done something positive with regard to step therapy legislation. And it could be anything on this list, but it doesn't mean it's everything on this list. And in order to really fix it, you've got to make it, much more locked down. If I've already been through this, don't make me do it again. Grandfather me. If it's contraindicated, you can't do that to the patient. If I've been on the other drug for a long time, don't make me go backwards. It's just there are a number of things on here, but that's a lot of states that have done something.
It is quite a lot of states that have done something. And Starlin, I see that your comment saying payers do not hold on to the patient's data so that there's not a longitudinal process of checking on the previous therapies. It is a barrier to access. It's a barrier to access when step therapy is in place. If my insurance changes on January 1st of next year, I now again have to prove that I have failed on 3 of my antidepressants. Even though I just did it within the last 12 months. That is absolutely silly. But looking to address the actual system and the fact that step therapy is in place is another way that we can address that too.
So I promised to get back to pharmacies. And there's a number of pharmacists in this wonderful group, and you all know this. The PBM practices are economically damaging pharmacies. On one hand, they're directing patients to their own pharmacy. On the other hand, they're not reimbursing pharmacies at a fair level. at the same level as an in-network. And the ones that really get hurt are the independent or community pharmacies the most. But honestly, they're hurting each other as well as from a chain perspective. If your CVS is hurting Walmart, et cetera, in this process. Reimbursement for drugs determined by the PBM contract may be lower than what the drugs actually cost the pharmacy to stock. They're literally losing money when they sell you or your patient the drug at the counter. And they can't make that up in Hallmark cards as you've walked through. Now you're driving through, you're not even walking in to buy Hallmark cards, or the other things that you could be buying, the shampoos and such. 2,275 pharmacies closed in the first 8 months of last year. I don't have a final number. Half of those were chain. Half of those were independents. This is a serious problem because patient access to care is getting worse, lower and lower and lower, worse and worse, and more jeopardized. Nearly 19,000 independent pharmacies operate in the United States. 2/3 of those serve communities with less than 50,000 residents. These folks are in jeopardy, and this business practice where they will send a reasonable, average wholesale cost payment to their own pharmacy and something far less than that to the independent or not out of network pharmacy. What you're going to find is pharmacies are closing, and we're seeing that happen. And we're also going to find pharmacies are not going to stock certain drugs because they can't afford it. And the clawback 6 months later, Stacy, this is so inherent in their contracts. And Stacy could probably go further into this than I even. I'm a mere accountant. Their contracts allow them to look back to say, did we have enough business with you? Did you meet all of those things that the pharmacy is not in a position to actually negotiate? As I mentioned, those 3 PBMs have 80% of the US drug market, and it's a play or don't play, but it's not let's go negotiate this contract. They can then 6 months after do a review of all the business that flowed through and decide, you know what, I overpaid you for this. You don't deserve this level because we didn't have enough business, so I'm going to pay you less. And then they just claw it back and take it from their bank account. Nobody can run a business that way. Nobody can run a business allowing somebody to take part of their revenue back. Or many of those in the pharmacy world know how slim those margins are. They're working on really, really slim operating margins. So we now are talking about PBM reform. It's more than just rebate pass-through. It's rebate pass-through. It's delinking their cost from the rebate, from the discounts. We still want the discounts and rebates to go to the patient. I don't want the PBM to get a percentage of it. It's not going to get rid of rebates, but it's going to delink their thing. We want to make sure the lowest cost drug, we even talk about this, is available to the patient, because the low cost drugs, the biosimilars, the generics, are being pushed out of formularies because the PBM makes more money on the branded drug. It now also includes, when we talk about advocacy, making sure that they're reimbursing independent pharmacies at the same level as their own. They have to do this, and many states have passed this. There's a lot of action going on at the state level on that level of PBM reform. That's something y'all, especially if you are in the pharmacy world, should be weighing in on and talking about and supporting, and we are as well in this. And the pharmacy associations are going into this. We've got to stop this. And what happens here, and Aaron, I'm not sure whether I'm taking this one, but I've touched on all of this from a clawback, the below cost based reimbursement, and it's causing a lot of problems. for the pharmacies themselves. And I do want to, let's just go to the dessert part, because this is where we should be putting ice cream on it. So Erin, give me the ice cream.
You got it. As a result of this and a lot of the challenges that PBMs are presenting, particularly to independent pharmacies, which are typically the ones that are in our rural communities, because they are driving them out of business due to their vertical integration and preferred steering practices, it's creating pharmacy deserts across the country. And this map here is devastating. And you can imagine that if someone is 10 miles from their nearest pharmacy, they are probably even farther from other necessary elements of healthcare. This all works together, right? And we know that so many of you are PharmDs and have chosen and decided to become a CDCES. And we're grateful for that, because you know as well as anyone that oftentimes pharmacies are patients' only or most likely access to care. If independent pharmacists are being driven out of business because of these practices, then we are not only creating pharmacy deserts, we're creating care deserts. George and I have a colleague that is a CDCES, also a PharmD, and also spends a little bit of time every week at an independent pharmacy. And she shared with us that they can no longer dispense Ozempic because they are losing so much money on it. They're losing $75 per prescription because this particular independent pharmacy that has been family owned and been in the community for a very long time is no longer able to dispense it. So if pharmacies are making those decisions, then not only are they being run out of business, but they're also keeping people out of their doors and out of those conversations, which is a challenge. And I know that we are just about on time, so I want to make sure that we get to the what can you do, right? George, we're 2 minutes over. We need to give Hannah 5
Sorry
minutes,
about
so
that.
you and I have 3.
Okay.
That's okay. You have an important role in PBM reform advocacy and in all advocacy. And because you're here, that is an excellent, excellent step. We're grateful for that. We encourage you to be part of the conversation. You all are so incredibly critical to patient care. We know that you not only face the administrative burdens of those prior auths and hearing people with their challenges when they're coming into the office, but you're also the ones administering care and sharing what folks should be doing and talking with them on the phone and texting with them. I say them, I mean us. I am them. We want to make sure that your perspectives are particularly brought into state houses and in conversations with policymakers. George?
And you guys have the both the patient perspective and the healthcare system perspective. And the legislators need to hear that. One of the breakout sessions we're just in, don't be afraid to use your voice. They need to hear it. And there are so many different ways to engage. Sign up. You're getting ADCES's action alerts, I know. Sign up to be a DPAC champion. Go to diabetespac.org. Get ours as well. Go to diabetes.org, the ADA site. Sign up to be an advocate with them as well. Go to Breakthrough T1D and sign up to be an advocate with them as well. You're going to hear some of the same, but you will hear some different things, and it'll tune you into things. It is not a competition in advocacy. This is a community. And so being aware of what's going on is really what you're here as an advocate. I need to know. I want to bury my head in the sand because I'm so ticked off, but I really need to know what's going on. And the way to know what's going on is being tuned into this. And it takes seconds to sign up for these things. They don't, they may ask you for money. To ignore that, just sign up. And you'll get the emails. They don't spam you on this kind of thing. Work with your own coordinating body. Work with us. If you've got questions, we're here. We love to answer your questions. So if you want something at your state coordinating body is looking for some resources, please don't hesitate to reach out. You're not bothering us. That's what we're here. What we love to do, and obviously Hannah as well. But I make that that offer freely for us to. We have information on everything we've spoken about. Be delighted to continue that dialogue to help if you've got something going on. We can't be in every state at the same time. So you may see something in your state that we may not even be tuned into because, again, omniscience is no longer my strength. Math isn't even my strength anymore. So I urge you to get involved. Another thing that we were going to throw in here is letters to the editor. And Hannah, we will share, we've got a letter to the editor guide, how to write one, etc. There's timings on when to do that, but there's
Did we
something we'd be
lose
delighted to
George or
share
did
that
you
you can
lose
do.
me?
I think we
Oh, I
lost
might,
you, Aaron.
Go
George, we can
ahead,
still hear
George.
you.
George, did we lose you or did you lose me?
can you all still hear me?
Yeah, we can hear George.
Okay, great.
Okay. So you've got all my info there. That's great. And Hannah, thank you so very much. And questions, thank you. Find us at Diabetes Pack. I know we've gone over, but Hannah, thank you so much for having us.
Thank you so much for being with us. You answered a lot of the questions as you were going in the chat. So really appreciate the lively conversation you were stimulating there. And Megan, let me just flag for you if we can try to save the chat somehow and maybe curate some of this for next week when we send follow-ups.
Yeah, we can save the chat.
Great, thank you. And you have both George and Aaron's emails there. All right, I just have about 5 minutes of closing. There's been a lot talked about today. I want you to leave here thinking about what problems were identified throughout the day, but also in your breakouts in your state and your region. What do you need to look into more? A lot of questions about how do I find out what policies are in my state. Resources were shared, and we will get more of those out to you about where to start. Who else from your state should be involved? That might have come up during your breakouts. And can you create a plan to follow up on any of these issues or even just this broad idea of diabetes advocacy in your state? If you're not already subscribed, I want to invite you to join us on ADCES Connect on the Advocacy Forum. QR code will take you there. We're sharing the slides out after the event. But this is where you can talk with other states as well to find out what they're doing. And a number of other COIs as well that may be great places for these conversations on ADCES Connect, open to any ADCES member. Make sure you go to the resources page for this. We have a report on AID access in Medicaid. We have resources from our event supporters on CGM's impact on the budget reconciliation law from over the summer, as well as obesity. Some of these are issues we talked about in last year's event as well. So there's more than just these 3 issues to be working on. And I wanted to flag, especially for those of you who are directly affiliated with a state health department, there is an upcoming opportunity to participate in the next cohort of the CGM Access Accelerator Program from the Helmsley Foundation. It's a multi-state learning collaborative to support state Medicaid agencies to expand access to CGMs. And they are currently planning the next phase, so you can get more information at that QR code, or you can email the CHCS team if you know that you are interested. No formal commitment or application open right now. They're just trying to test the waters, gauge the interest, so make sure to reach out. I want to thank our State Policy Forum sponsors one more time. My gratitude goes out to Dexcom, Insulet, Lilly, and Medtronic for their leadership and in supporting this event in its 2nd year. And again, want to acknowledge their year-round partnership on state and federal advocacy issues and their participation in many of the coalitions the ADCES is involved in. And if you are a leader within your coordinating body and are interested in formally working on really anything advocacy related in your state, please be in touch if I can be of assistance. I'm here to help you with brainstorming, planning, connecting you with other associations or organizations like the 3 that we heard from today. And with that, please complete the survey afterwards. That's all we have for you today. Really appreciate those of you who have stuck around to the end of the day. It's a long day. We got it 30 minutes shorter than last year, but there's always so much more to say and not enough time to fit everything in. So thank you again, everyone, for being here, and we hope you'll join us for the event next year. You can tell us what topics you want to hear about in the survey, so please take it. Have a great afternoon, everyone.